Good morning. So I really want to welcome everyone. It's a big pleasure to open APCCC 2024. I'm Siki Gilson, I'm a medical oncologist, and I give to Aurelio Zomlin, who is my co-chair.
Good morning also from my side. It's a great pleasure to see you all here. I know some people are still at the registration printing badges, but we said we start in time because we have a very full morning with lots of exciting sessions to talk about.
Perfect. And then we show you now, hopefully. This is our panel, so that you know who was voting on the questions. You see, it's a very big panel this time. It's very international, very interdisciplinary. And some of these people you see already on stage. And we want to really give a special thank you to the scientific committee who helped us with the questions, with the program. And I hope you're all happy and please give your feedback. They're all here. So if you want to give a direct feedback, there's a lot of breaks, as you know. The only one who's missing is Eric Small, and he's the president-elect for ASCO this year, so we're very proud. He's in our scientific committee, and he had to go to an ASCO meeting, but he sends his regards. So for all of you who are here the first time, we developed 180 or more than 180 consensus questions. And these have been developed by the APCCC Scientific Committee and then really looked at and corrected and so on by the whole expert panel that you saw on the first slide. The voting took place prior to the conference, so everyone has a bit time to think about the answers. And we will discuss the most interesting voting results, so very fresh, nobody has seen them except Aurelius and me, after the sessions. And we want to really give a special thank you to our friends Thomas Seeley, Bertrand Tombal, Karim Fizazi, and Nick James, who came to Basel for a whole weekend and really developed the questions. Oh, I get by with a little help. So this was before, but not last time. I get high with a little help from my friend. Gonna try.
As you may know, APCCC never ends after the meeting because we then work on the consensus publications. For those who have not seen them, the 2022 publications are listed here. We did split it in two parts, and we have, I'm proud to say, already started on the manuscript 2024 because that always takes quite a long time. And you can help us. You will see a lot of activity on social media by also disseminating the results, because APCCC is really for you, for the people who see patients with advanced prostate cancer all around the world. So we need to make sure that the findings, then the reports and the videos that will be online after the meeting get disseminated. We will talk about that a little bit later. As always, of course, such a big conference and bringing in such an amazing panel would not be possible without support from industry. And I would like to express a special thanks to the gold sponsors, Amgen, Bayer, Lilly, Pfizer, Novartis, and Janssen Oncology. Of course, I would also like to acknowledge the silver sponsors and the sponsors that have otherwise supported APCCC 2024. Thank you. A special thanks goes also to the Città di Lugano for making it a nice and bright sunny day today. They also support the conference, which is very important. And I would also like to express our special gratitude to the Movember Foundation. We will have a special session tomorrow morning at 8:30 where we talk about the Ironman project. The European School of Oncology Foundation and also PCF support APCCC 2024. Thank you very much.
And we also want to thank the great organization team that we have, Laura Di Petto and all the team. So if you see them outside, if you have questions, if you need help, they're really here for every one of you. And then, again, for the ones who weren't here, we don't have tones, we have gold bells. This is this one. So the chair can remind the speaker that it has only 5 minutes left because we really want to be in time. We are in Switzerland. 1 minute, sorry. And when the time is really used up, we use the cowbell. So this is the chairs who have to do that, but I think all the speakers are already afraid of the cowbell. I hope at least. Martin, right? A bit afraid. Okay, very good. So I gave you also a save of the date. So as you know, APCCC is only 2 years. So next time in 2026. But we have a new conference ongoing, that's APCCC Diagnostics. That will be February next year, also in Lugano. And you see here, responsibles are Ken and Stefano Fanti. So if you see them, and if you're interested in imaging, diagnostics, molecular markers, you should come also in February next year. We are stuck, but anyway, what we say now is we come now to a very important part of the conference. David Matheson is here, like also 2 years ago, to give us the patient's perspective. So what are you wanting from this conference? So thank you very much, David, for coming again. Thank you.
Thank you very much. It's a pleasure to be here, as always. Now, hopefully this thing will work. Does it work? No. It works. Right, what's important from a patient perspective? Well, I'd ask to give us some disclosures first. Go on. Pointing the wrong way. So there's my disclosures. I'm a patient representative in the Stampede trial. I'm also a patient representative of Libertas trial and patient representative, advocate and volunteer with Prostate Cancer UK and Prostate Cancer Research, also in the UK. Now, last time I talked about the strands that there are to a patient's life in the context. And I said there's two strands, really, to a patient's life. There's illness, that's what gets them to come and actually seek treatment, but there's also wellness. And I talked about how patients can be well within the context of prostate cancer. And I showed a couple of what used to be called Wordles, but then the New York Times decided Wordle meant something else. Speech, word frames, word bubbles. And there's the two of them. This came out of work that Catherine Matheson, Monia and I did, and it's still ongoing really, about what it is to be well in the context of prostate cancer. And as you can see, we've got illness, things like side effects and so on, but we've got wellness as well. And I think, I'm not going to dwell on this for much longer, there's another thread that I want to pick up. But if you think about it, patient comes to you with the disease, or suspicion of the disease, fear of the disease, whatever, but they're bringing the whole life with them. And within that life, there's another aspect, and that's hope. People come with hope. They come with the hope, for example, that they won't actually have prostate cancer. That's a hope which is all too frequently dashed. They come with the hope that if they do actually have prostate cancer, then certain things are going to unfold on the basis of that. So, there's hope for a cure. I hope for a cure. I was originally diagnosed I got my formal diagnosis in September 2012. Still with us. I've metastasized a couple of times, but, or my tumours have rather than me. So, I still hope for a cure. Like many others, I hope for manageable side effects. Every treatment has its side effects. I live still with the side effects of my original treatment. I live with the side effects of my subsequent treatments. All patients want these to be manageable. If you can't actually cure us, make life as livable as possible. And that's a hope which is hung on to very strongly. And again, so this came out in the work that Catherine and I did as well, what people hope for. Not for pain relief that works. We don't want to be in agony. I mean, discomfort we can cope with. You can adjust to discomfort, but agony, stabbing pains, these kind of things, we don't want to have. But also, we don't want to have pain relief that leaves us feeling like a zombie. We want to remain compos mentis, even if it's painful. Compos mentis in the here and now, and also with minimal side effects to the pain relief. We want clinicians who listen. We want them to actually attend to what is said. Now, there has been work done over a number of years about how long it takes a clinician to interrupt a patient during a consultation. When clinicians were asked, they measure it in minutes. When patients were asked, a rather different answer. But when they're actually observed, sometimes it took seconds. If it takes seconds, that means you're not attending to what's being said. There's a plan. Now, we know that often consultations are quite hurried and rushed and so on, but you've still got to be able to listen. Listen to what's been said. Seek to understand what it is for that patient to actually be living the experience that they're living. Treat the patient as an individual. They're an individual with a context. They're not just the carrier of a disease or a carrier of side effects from treatment from the disease and so on. They have a context. They have life. We also want a society that shows greater understanding. Thanks to a lot of publicity campaigns around prostate cancer and seeking early treatment, early diagnosis and so on, there's a misconception out there that it's a good cancer. And I'm sick of having to remind people there are no good cancers. They're all awful. Some are even more awful than others, but they are all awful. So we want a society that shows better understanding of the disease, of the effects of the treatments. It's quite a conversation stopper for someone born male to be on hormone deprivation therapy and to have emotional fragility and just burst into tears for no reason. Just there, boom. And start weeping and sobbing. And the reaction is very seldom positive. And that's something where I think greater understanding can certainly be engendered. So, I think that helps hope is a proper quality of life tool. We want things to have a purpose. And quality of life tools, in my experience, often seem to be, let's say, not so much for the benefit of the patient. So here's a little plea out for you. How about a quality of life tool whose purpose is clear? I've done a fair few of these, and if I didn't do what I do besides being a patient, I'd have no idea what they're actually for. I want a quality of life tool that adapts to the patient. That doesn't assume we're all the same, because we're not. We're all individual. I want something that's dynamic, that isn't static. Now, if you have any experience of designing questionnaires, doing this kind of thing, in principle, is a doddle. Getting the right questions, that's a bit more difficult, but the principle is quite straightforward. Don't make it a Procrustean bed. We can't all be stretched to fit or have our feet cut off, as in the myth of Procrusteus. I want something that feeds back into the patient's medical record, rather than being cast off into the wind, never to be seen again. Because ask intimate questions. If somebody asks me intimate questions, do something with it. Show me that you're doing something with it. Do something for me with it, besides helping others. Very happy to help others, but help me, help the patient. So, because if this goes into the medical records, it helps the clinician ask the right questions. It stimulates the clinician to remember this is an individual with an individual context and so on. Helps them listen to the answers and act upon them. And so we need a quality of life measure that benefits the patient. Not just the trial, not just patients in general, but the individual, because that's what we are. We're individuals and need to be treated as such. So, to help along that way, a couple of little references. One already published with myself and a couple of others, but quality of life measures from a patient's perspective, capturing the heterogeneity of the patient experience in a standardized way. It's 1,000 words long. It will take you, according to ResearchGate, I think 1.5 minutes to read. That depends how fast you read. And there's another one coming out in the near future with myself and a few others, so just watch out for these. So, thank you very much for your attention.
Thank you very much, David. I think this is really, we have to keep that in mind for all the discussions that come in the next 2.5 days. Before I give to the chairs of the first session, I want to say that we had our friend Felix Feng plan to be here and speak about genomic classifiers and artificial intelligence. And unfortunately, he couldn't come because he has a health issue. And I really want to take the opportunity to thank him for all what he has done in general and also for APCCC. And we really send our best wishes to San Francisco to him. And I also want to thank Dan Spratt, who has really spontaneously taken his talk, and you're getting some sweets for that as well. So now, Neil and Neha, I'll leave it all to you.
Okay. Thanks very much, Silke and Aurelius, for allowing us all to be here and enjoy this amazing meeting. Our first speaker is a good friend and colleague, Martin Gleave, who will speak on high-risk and locally advanced prostate cancer in the context of current diagnostic and therapeutic options, which is the ideal definition to use for clinical practice.
Great, thank you for the opportunity to speak. And I was assigned this topic, which I think we all are challenged in terms of defining, even though we all kind of know what it is when we see it. I think, risk stratification is a key part of optimizing outcomes in high-risk prostate cancer. And we've been trying to estimate this risk with a number of different approaches over the past decades, starting with Parton tables, the D'Amico criteria, various nomograms, as well as consensus definitions like NCCN, and I'll get into many of these over the next 10 minutes or so. And our focus here is not so much on the broad spectrum of low and intermediate risk, but really how are we stretching out and better defining the high-risk spectrum of localized prostate cancer. And this matters, as in this review by Daria Tilke, that there are 7 definitions roughly for high-risk prostate cancer. And when you look at BCR-free survival or metastasis-free survival, these are stretched out across a pretty broad risk category. And it ranges from, at least if you look at a endpoint that matters, metastasis-free survival, it varies from 77% if you just look at PSA greater than 20, to about 56% if you just look at high-grade Gleason 9 or 10. So again, there's room for improvement in terms of better categorizing risk, which is important when you're talking about intensifying, de-intensifying treatment, or for clinical trial criteria. And I'll just highlight this one paper from Hopkins, a retrospective review of 750 patients, NCCN high-risk localized prostate cancer defined by Gleason score 8 to 10, PSA greater than 20, or clinical stage T3, and they defined a very high-risk group as those with primary pattern 5, greater than 5 cores of Gleason score 8 to 10, or again, I think most importantly here, the accumulation or multiple high-risk factors tend to then increase the risk of metastasis or cancer-specific mortality several-fold. When you look at defining criteria for entrance into clinical trials and how we've struggled with this, CALGV is a classic example of this, where 750 men with high-risk disease were intended to enroll in this study, did enroll in this study. Initially, risk criteria was determined by the Catan nomogram, predicting a probability of freedom from biochemical recurrence of less than 60%. But they found that that accrual was hampered by this. It was too stringent a definition, and the protocol was later amended to enroll men with Gleason score 8 to 10 and less than a 60% probability by a Catan nomogram. So again, defining risk also has to include the proportion of patients who may be then eligible for that trial. Another evolving area in defining risk is estimating volume. Clearly, risk is determined by tumor volume, which is stage, as well as number of cores, by grade, and also by IPSA. And so you can, I think we're all familiar with the diverse area here. You can either be a T3A, Gleason score 4+4, and multiple cores, and a PSA of 40 is going to be worse than a similarly staged T3A and a Gleason score 4+4 and only 2 cores with the same PSA. And so CAPRA is set out to better define risk on the basis of percent of positive cores. So if you're greater than 33%, integrating this into their definition of risk better predicted prostate cancer-specific mortality independent of treatment validation. Similar to NCCN, high risk versus very high risk was improved by recording the plus or minus less than or greater than 50% involvement by cores. And I think when you look at guidelines, nomograms for risk, NCCN unfavorable intermediate risk involves 1 or more of 2 or 3 intermediate risk factors, which is T2B, Gleason grade 2 or 3, and a PSA of 10 to 20, or grade group 3 or greater than 50% positive cores. High risk, no very high risk features, and only 1 high risk feature of either T3, grade group 4 or 5, PSA greater than 20. And then you've got the very high risk group, which includes T3B, pattern 5, grade group 5 or greater than 1 risk factor. With Stampede, which is more geared towards a perhaps radiotherapy targeted group, 2 or more risk factors of T3 for PSA greater than 40 or Gleason 8 to 10. The only issue I have with these definitions is I think it's very difficult to quantify and differentiate a T2B versus a T3A cancer. It's very dependent on interpretation and subject to bias along the way. So I think, again, DRE inaccuracy in distinguishing T2 versus 3, and we have to, I think, evolve its use and include more volume of positive cores. Nomograms have been developed, and I list a few here in predicting lymph node metastasis, and these I think will have to be modified in the future based upon the role of PSMA PET in this state as well. I think that we're all familiar with the challenges. I think this is a multifocal, multiclonal disease which underpins intrapatient spatial heterogeneity. We have imperfect imaging and biopsy with undersampling that limits accuracy of prognostic subgrouping. These are all the things that we're struggling with moving forward. T-stage is highly subjective. Grade-defined high risk can be misleading as to whether or not you're high volume 4+4 or low volume 4+4 versus a high volume 4+3 or a 3+4 high volume with a higher PSA. How do we weigh systematic versus MRI targeted cores in determining risk? This is an evolving area because of patterns of practice of whether or not you do targeted plus or minus systematic. But I think in general, the most important is the presence of pattern 5 and volume of pattern 4, and increasingly the use of PSMA PET to better estimate risk of regional versus non-regional metastasis. There are a number of trials that are now integrating risks for inclusion criteria that are contemporary, Proteus and GUNS, all enriched for either high volume, high intraprostatic tumor volume and grade, and ultimately risk of metastatic recurrence. And in these trials, they define high-risk localized prostate cancer as either Gleason 4 greater than 4+3 and at least one of the following, any combination of 4+3 and 4+4 in greater than 6 systematic cores, any combination of Gleason score 4+3 and or 8 in greater than 3 systematic cores with a high PSA, any Gleason score 9 in at least 1 systematic core, or at least 2 systematic or targeted cores with a Gleason score 8, all attempting to actually incorporate high intraprostatic volume along with grade as an estimate of risk and metastasis. ASCO guidelines for tissue-based biomarkers. Obviously, genomics is helping to stratify risk, and Dan is going to talk to this into the future, but I think currently these are very useful in differentiating risk at the low and intermediate risk level rather than further categorizing risk in the high-risk groups. When we look at treatment intensification, I just give this one example from Stampede, 2 phase 3 randomized trials in the M0 subgroup, very high-risk group, randomized to receive radiation and ADT plus or minus ABI. Over 1,900 patients with high-risk, quote-unquote, non-metastatic disease, because they could be N positive, and at least 2 of either T3 or T4, Gleason 8 to 10, or PSA above 40, or relapsing less than 12 months of ADT or greater than 12 months post-treatment and a PSA greater than 4. And their intensification by adding ABI significantly reduced metastasis-free survival and overall survival, again, identifying a subgroup that was very high risk that benefited from intensification with ARPI doublets. So again, just ending, I think that clearly defining high risk is a spectrum, and we can extend this risk into low and intermediate risk, but in a high risk group, it extends from either low tier to a very high risk, or even now regionally very high risk disease with the use of PSMA PET. And this can be modified in a kind of in a concluding slide where we can think about high risk disease in a modified NCCN format, where again, this has to be pragmatic, useful in the clinic. And we can think about breaking down high risk into 4 tiers. Tier 1 has no very high risk features like current low tier high risk in NCCN, and only 1 high risk feature of less than 3 cores grade group 4, greater than 5 cores of grade group 3, and either a T3A or PSA greater than 20. A tier 2 includes greater than 4. That's 1 minute to go, right? Okay, thank you. There's something that's come up, thank you. Or a T2 risk group greater than 4 cores of grade group 4, or less than 3 cores of grade group 5, and or 2 of the tier 1 risk factors, and so on and so forth. So you can build these different tier groups based upon risk, ending with a kind of a very high risk tier 4, which is either a high grade cancer and extrapelvic or M1A PSMA detected metastasis, and or greater than 2 tier risk groups. I think that increasingly M status is going to be PSMA PET derived, which leads to a selection or a stage migration that we have to incorporate. And we can think about incorporating things like histologic variants into this definition as well. So thank you for your attention.
Our next speaker will be Dr. Declan Murphy, who will speak to us today on whether digital rectal examination for definition of local T-stage still appropriate in the time of MRI and next-generation imaging. Welcome.
Thank you, Neha. Thank you, Silke and Aurelius, for addressing the glamorous topic of digital rectal examination. But this is a very important topic, as David set up very nicely for us this morning. And there was a very nice piece written in the British Journal of General Practice recently. Is this one supposed to go forward? Tap here. Or next slide, please, if someone can advance. Thank you. British Journal of General Practice recently, which reports a survey from Prostate Cancer UK of about 2,000 men addressing the fear of digital rectal examination. And look at this, 60% of this group of men are concerned about DRE, a third of whom are so concerned that it's the reason that they're not going to go and see the GP. And black men within that survey were significantly more concerned due to cultural issues, despite them being at higher risk of mortality. So I think that's the background to a discussion about the role of DRE, is it is preventing many men from going to seek advice from their doctors about about prostate issues. And while there are lots of memes and videos and so on, that's not really helping. And I think what we need to do as clinicians is have a more nuanced advice towards the role of DRE. So this is the obvious question, do we need to do DRE in an era when we have MR? And that's the whole backdrop, I think, to a conversation about DRE in 2024. It hinges on MRI, but it also hinges on which world do you live in. If you live in the idyllic APCCC world, which, by the way, what's written here is what Silke and Aurelius write on the top of the panel questions every year, assume that everything's available and free. So that's the only way in which MR makes a difference for DRE. But of course, in the real world, MRI is actually usually not available for very many of you and your patients. Even in high-income countries like the US, which has probably the greatest of all health disparity, MR is not available for huge swathes of the uninsured at-risk population. So that's the backdrop as we discuss the role of DRE. So I have 3 different scenarios that I'll discuss. First is primary care, where I suppose imaging doesn't really come into it. Well, let's presume that we're talking about the at-risk asymptomatic screening type population and presume that MR is not really available for most of these regions around the world. And of course, DRE in this setting has poor sensitivity. There are concerns about the experience general practitioners have of DRE, and as I've pointed out, the patient perception. And yes, before you all tell the stories of that rock-hard prostate with a PSA of 1.1 that we've all seen, remember that to balance that off against the huge deterrent that DRE is in primary care, we need to have a view that's not just about the rare patient who has a low PSA and a nasty cancer, who usually will develop some symptoms. So it's not that we're really concerned about. And there are 2 recent papers, 2 papers I'll quickly show to you that really kill off the role of DRE in this GP setting. This is a nice systematic review in European Urology Oncology led by Shirok Shariat and team. And what they conclude in brief is when looking at both positive predictive value for significant cancer and cancer detection rates, DRE is the same as just PSA on its own, and even worse for cancer detection rates. And Chirac sent out a triumphant tweet in January when the paper was published saying, finally, he's proven that DRE has no role in the early detection GP screening setting, and hopefully this will begin to appear in guidelines. And that systematic review did not even include this nice paper from Peter Alber's group in Germany, published a few months ago in European Urology Oncology as well, the PROBASE trial, a prospective screening trial starting from men aged 45. And in this paper, Peter's group were asking, what is the utility of DRE in the screening population? The answer, really useless. DRE has poor diagnostic performance. That's the main headline coming out of this study, which I think will feed into guideline recommendations going forward and really question the role of DRE. So that's my sense of this. I don't think there's a real role for DRE. Little caveat and a shout out to Scott Egener, urologist in Chicago, who has a summary tweet here from last year about the role of DRE. He comments that he finds it useful for determining PSA density. So he must be quite good at estimating prostate volume with his finger. I'm no good at doing that. I can't, from one day to the next, the same patient could have a gigantic difference in what I think the size of his thing is. But I think the key message here is, in primary care, there's no real role, even notwithstanding those patients with low PSA and nasty cancer. This is the really interesting area. What about urologists, those of us who diagnose men with prostate cancer? And let's first of all consider the idyllic APCCC world where MRI is available. And we've all got very used, of course, with novel imaging showing, and this is just a patient of mine from last Friday. I'm only going to show you a beautiful case, of course, but it happens to be one from last week. The MR is very convincing. The PSMA PET is very convincing. The final pathology confirms it. But I want you to look at the T2 image in the top left where, this actually feels just like a clinical T2. You can just about feel it. But on MR, it looks like it is T3. It is extracapsular extension. And the final pathology, that yellow line, is all extracapsular extension. So I think Martin's question about, the futility and lack of reproducibility of CT examination, clinical examination, needs to be questioned in the era of novel imaging and grade volume, as he says, core volume. But I will remind you of the precision study, the one key paper that has really changed practice for us when it was published in 2018. And by the way, only 15% of patients in this study have an abnormal DRE, a classic at-risk population. In the control arm, without MR, we see 26% detection of clinically significant cancer and 22% detection of insignificant cancer. But when you bring the MR triage pathway in, suddenly the really important thing is the insignificant cancer drops to 9%. So by using an MR pathway, forget about the DRE. What we're really doing is leading to much less overdiagnosis of prostate cancer. So I think the idea of the virtual DRE, where MR is replacing that as a tool for deciding who needs a biopsy or not, is really, really important. And I'll give a shout to Nick, who's speaking in the final session about the Lancet Commission in a very important session here today. His nice paper published in Lancet recently addresses a whole load of stuff about prostate cancer, but in particular for high-income countries with MR, he mentions, or the group mentions, that we must link MR in the early detection pathway to reduce over-detection. But in the real world, what do we think about this for APCCC? Very little role. That's by conclusion. I rarely do a DRE if I'm planning to do an MRI. I sometimes do it at the time of a biopsy if it looks like it will be T1 disease, just to make sure. And I don't do a DRE if the MRI is normal. If it's a telehealth consultation, the patient's had an MR, it looks normal. And that's our key message, I think, is DRE has little role for urologists who use MRI. But what about the real world? MRI is not widely available. That's the reality, and therefore DRE still remains an essential tool for determining, does this patient, will I recommend a biopsy for this patient or not? So if there is palpable disease, we clearly will because of the high positive predictive value for significant disease. And as Martin highlighted, it still is a key part of risk stratification. So I think if you don't have access to an MR and your patient is referred in with a high PSA, yes, digital examination done by the urologist still has an important role if MR is not available. Final scenario, local staging. What's the role of DRE and local staging in the world where everybody has an MR? Well, MR is clearly the best tool for giving us local staging information. But I will still always do a DRE if it's been suggested this patient has extracapsular extension to see does it feel clinically T3, i.e. high-risk patient, because that still determines, for example, if the patient's having radiation, at least in a conventional era without genomics, that they will have 2 years of ADT, for example, just based on the clinical T3. So I think the finger still remains important, but we would all love to hear Martin's wish for a revision of these systems to come through. And clearly for regional staging, PSMA PET CT will reign supreme. But in the real world, again, MR is not available. CT is no good for local staging of the prostate itself, so DRE still has a key role for the urologist looking after a patient who's already been diagnosed with cancer, and we're trying to plan best treatment for that patient. Now, I'm not showing the answer, Silke, but we will be looking at the answer to this question. So this is one of the questions this year, so I want you to think about this. Silke and Aurelia said, in the majority of patients that are clinically T2, okay, so we can feel a little nodule, but the MR clearly shows T3 disease, what do we recommend? Do we call it T2 or do we call it T3? So obviously I voted T2 because it's clinically T2, but I'm interested to see what the vote says afterwards, because it's quite a big difference in the planning. Finally, PSMA PET CT, is there a role in early detection for these patients? Well, clearly when we started doing PSMA PET for regional disease, we begin to see examples like this where PSMA can tell us a lot about what's going on in the prostate. But clearly we're not going to do a PSMA PET for every man with a raised PSA if they've already had an MR. In the primary study we did, though, to see what was the additive value of doing a PSMA PET CT, and we did show that it increased the negative predictive value, but I think where that's really interesting is in the patients with a normal MR or equivocal MR, the ones we would traditionally biopsy, but maybe they don't need a biopsy. And you can see in the bottom left, yes, if we did a PSMA PET and it's negative, a lot of patients avoid a biopsy. So we follow that with a randomized trial, which is currently underway to determine what the role of PSMA is. There are my final thoughts on that. Silke, thank you very much.
So now we have Professor Jochen Walz, who will talk on regional lymph node staging for high-risk and locally advanced prostate cancer. What should be the standard?
Thank you very much, Neil, for the introduction. Silke, Aurelius, thank you very much for this invitation to this yet another great meeting to be coming up here in the next 2 days, and to talk about lymph nodes, which is still like a very hot topic now for decades, basically, in prostate cancer. These are my disclosures relevant for this presentation. I would like to concentrate on what I consider being the 3 burning questions we have with regards of lymph nodes now in the management of prostate cancer. The first one being, what is the most reliable method to stage our patients with regards of the lymph nodes? The second one being, what is the role of PSMA PET in this situation, especially when it's negative? Can we skip the lymph node dissection in this situation? And the third one, the burning question, is the lymph node dissection a staging procedure, or does it have also a therapeutic effect on our patients? The current standard is the extended pelvic lymph node dissection, and you need to be aware that it is very effective. You do what we call an extended pelvic lymph node dissection, taking out the nodes from the external iliac vessels down to the obturator fossa, further down to the internal iliac vessels, and maybe some nodes from the presacral area. You will correctly stage 94% of all our patients with regards of the presence or absence of lymph node metastases. And that is relative to a super extended pelvic lymph node dissection you see down there on the left-hand side, where you would go up to the inferior mesenteric artery. This is a procedure which basically takes 3 to 4 hours, and just by concentrating on the area that I was showing you on the right-hand side gives you a very high reliability to stage your patients. At the same time, you will remove basically 90% of all positive nodes. So from a diagnostic point of view, it is very effective, and the bar is very high to compete with this, and this does also add some therapeutic effect to it if ever you consider this being present for a lymph node dissection. And this is the current standard of lymph node staging in prostate cancer patients. But we have now PSMA that was already mentioned at several occasions this morning. And this is the great pro-PSMA study from Australia that clearly showed that PSMA is doing better than conventional imaging with regards of the area under the curve, the sensitivity, and the specificity. But if we would like to answer the question if we can skip lymph node dissection if PSMA is negative, we need to have a look at the negative predictive value. That is the diagnostic value that tells you if a test is negative, that the outcome that the test is supposed to predict really is not present in a patient. And if you look at what I consider high-quality studies, prospectively done, more than 100 patients included, and using lymph node dissection as the reference to see if there are lymph node metastases or not, you end up by having a negative predictive value somewhere around 80 to 90%. This looks really good, but be a little bit careful. What is the negative predictive value? It actually is calculated by taking the true negatives divided by the true negatives plus the false negatives. And I would like to do a short assumption with you. Let's take 100 patients that were staged for lymph node metastases. And the test said all of them are negative. And then you have 6 patients that actually do have N1 disease after the radical prostatectomy and the lymph node dissection. That would make the true negatives 94, plus the false negative plus 6, makes a negative predictive value of 0.94. Looks very, very good, but actually you would miss all of the events. All the N1 events would be missed. The sensitivity is 0. So you cannot rely on the negative predictive value without having a look at the sensitivity of the same test. And how good is the sensitivity? Once more, the pro-PSMA study. You see on the right-hand side the sensitivity for lymph node metastases, somewhere around 80%. But be aware that is not lymph node dissection being the reference, it's a composite endpoint, imaging, PSA, follow-up, and so on. But if you look at the lymph node dissection as the reference, you see that the sensitivity on the left-hand right drops to 40%, repeatedly 40% in 4 studies. There's one outlier who would like to call it 50%, but not sure that the sensitivity of 50% is really good enough. And you see on the right-hand side the negative predictive value. You need to be aware that the negative predictive value strongly depends on the incidence. Actually, the worst negative predictive value that you can get is 100 minus the incidence, and if you would calculate those, you would be very close to what you see on the right-hand side. So without a performing sensitivity, a good sensitivity, you cannot rely on the negative predictive value because it depends so much on the incidence. It's not only myself telling you this. This is a recent meta-analysis, a systematic review done by Armando Stabile, who looked at the negative predictive value of PSMA to rule out the need of lymph node dissection. And he observed the same observation. The higher the likelihood of finding lymph node metastases, the higher the risk strata of the patients, the lower the negative predictive value. And he very correctly concludes that in high-risk prostate cancer patients, a negative PSMA PET cannot replace a staging extended pelvic lymph node dissection. And if we would like to formally conclude what is the role of PSMA in this situation, we need to wait for the results of PSMA Select. Roderick Vandenberg is running this trial in the Netherlands, really trying to triage the patient before surgery using PSMA to decide whether lymph node dissection should be done or not. And I hope we will have these results in the near future. But how about the therapeutic effect of the pelvic lymph node dissection? We have 2 prospectively randomized trials available, the first one being the Brazilian Lestingi trial, 300 patients included, an extended pelvic lymph node dissection versus a limited one, 70 nodes with 3 nodes, and you see on the right-hand side the primary outcome, biochemical recurrence-free survival, no difference between the 2 arms. It is a negative study. And then we have Karim Tourget's trial from the US, from APCCC, and he just presented here an update 3 weeks ago in Paris at the EAU 24, and he included 1,400 patients, compared here also a limited with an extended pelvic lymph node dissection, only 12 nodes versus 14 nodes. That is one of the main criticisms we have here, but for the primary outcome, once more, you see here there's no difference with regards of the biochemical recurrence-free survival between the 2 groups. Looks like this is once more a negative study. But with a longer follow-up, actually, he was able to look at other harder endpoints, such as metastasis-free survival, distance metastasis-free survival, and you see here clearly a difference favoring the extended pelvic lymph node dissection. It is unclear why we don't see a signal for the biochemical recurrence-free survival, but a strong signal for the harder endpoints, but that's how the data is. And they have quite an amount of events here, over 150 patients developing metastases, so that is a strong statistic, if you want so. And it seems that the difference is generated in those patients who are node positive. You have positive lymph nodes, you're undergoing an extended pelvic lymph node dissection, you will reduce the risk of developing distant metastases by half, and you have a very strong statistical significance below 0.001. And the study was criticized because of the little difference with regards of the lymph node count between the two groups. But independent of the lymph node count, you see that effect favoring extended pelvic lymph node dissection, concluding it's not the amount of nodes that makes a difference, but the area where you take the nodes out. And this is well known. This is the Listinghi trial. If you do a limited one, you will have the operator nerve cleared, and you will have only in few cases the positive nodes in this area. If you go to the internal iliac vessels, you will have 65% of all positive nodes in this area. So you take out the right nodes, you will change the outcome of the patient. You will reduce the risk of developing distal metastases in these patients. So take care to take out these nodes here, and you will change the outcome of the patient. And then we have new technologies available for our patients nowadays. We have radio-guided surgery. We can link PSMA to technetium, then get an gamma emission during surgery, taking a gamma probe, and we will be able to identify those positive nodes inside of the pelvic field. We can also use fluorescence, as you see on the right-hand side, having PSMA linked to a fluorescence marker, and you will then be able to identify the right nodes, which will increase the therapeutic approach as well as the diagnostic performance of this test. So in conclusion, to answer the three burning questions that we have, the gold standard, the current standard for reliable staging of the lymph nodes of a prostate cancer patient is still the extended pelvic lymph node dissection, and that is also confirmed by the guidelines. With regards of the PSMA to skip the lymph node dissection or not being able to do so, I don't think that the current data allows that, but it makes a lot of sense to integrate now PSMA into the predictive tools in order to better stratify our patients. And it looks like that EPLD finally does have therapeutic effect on the development of distal metastases, even though we do not really understand the current mechanism behind this. And with this, I thank you very much for your attention.
And our next speaker will be Dr. Dan Spratt on genomic classifiers and artificial intelligence as predictors for treatment benefit.
All right. Thank you so much. I'm going to take whatever extra time he didn't use, if that's allowed. But really, as Silke mentioned, this is going to be Felix Fang to give this talk, and it's a real honor to give it for him. So I'm hyper-simplifying the NCCN guidelines for what I'm going to talk about today of decisions of when we add short-term hormone therapy, long-term hormone therapy, and now a consideration of abiraterone. And the basis, what is the primary biomarker in NCCN risk groups? Well, it's Gleason score, and this is the Gleason system taken from the work from about 60 years ago based upon 7 PCSM events. Obviously, it should not surprise any of you that a system 60 years ago does not perform very well in contemporary randomized phase 3 trial patients that has a C-index or discriminatory value of barely better than a coin flip, to use Gleason, which is how we're deciding this. So if you look at MARCAP, which is the largest independent patient data of almost all the randomized trials of radiation with systemic therapy, you can see that the use of hormone therapy here on the left versus not with radiation. The top, just to simplify it, improves MFS as well as OS, and these are the number needed to treat based on risk group of intermediate or high risk. And this is the same for prolongation from short to long-term ADT. Similarly, pretty low number needed to treat to prevent a distant met at 10 years with, again, improvements in MFS and OS. New kid is abiraterone based on the STAMPEDE data, as you see here. I like to highlight just to compare and contrast. Well, this is phenomenal work. These are not like any of the TROG, EORTC, or NRG trials. 25% of patients did have PSAs, and this is based on the selection criteria that Dr. Gleave already went over. And there was patients with PSAs into the thousands, but these are M0 patients. So, you know, it's actually interesting because I have Nick James and Vidang Murthy sitting next to each other. So I'm overlapping here. This is not meant to be, this is really for illustration. The POP-RT trial, which is a pretty high risk contemporary trial, almost all were PSMA PET staged to rule out N or M disease, versus the STAMPEDE's control arm. So these are both trials that got radiation with long-term hormone therapy, no abiraterone. And the difference here is pretty pronounced. There's only about a 5% biochemical recurrence at 5 years in the POP-RT trial versus almost a 15% death from prostate cancer at the same time point in STAMPEDE. These are not the same patients. So let's get into how do we personalize these decisions with contemporary tools. So the use of hormone therapy, and I won't be going into full detail, I would recommend you actually read a pretty expanded section we've now added to the NCCN guidelines, talks about genomic classifiers. There are three. The primary one that is used is the Decipher 22 gene. It has Simon level evidence 1 versus the others which don't have this type of evidence. And it has a section now, it actually goes into detail if you have level 1 evidence to the trial data to support it. But really, this level 1 data comes from about 11 phase 3 randomized trials. Some were pre-specified, some are post hoc, shown here. And what's relevant in this use of hormone therapy setting is these are two studies. One on the left is sort of a registry from Princess Margaret. The right is a randomized phase 3 trial we just reported. Both of these were intermediate risk patients, mostly unfavorable intermediate risk, got radiation alone, did not get hormone therapy. And the Decipher low patients, as you see on the top, almost none developed distant Mets long term. Decipher high, almost 20%. Obviously, ADT cannot provide probably a large benefit in the Decipher low patients. Shown in the bottom left here, you can see here, similar to what I showed you earlier, the AUC for just the NCCN favorable versus unfavorable has 0.54, again, barely better than a coin flip. The clinical genomic risk groups with Decipher 0.89, so very good discrimination. And the right is just showing you that Gleason score, again, fairly poor at really identifying. There's a massive on the y-axis. These are the Decipher GC scores, a lot of heterogeneity here. So the newest, which I've been very fortunate to be a part of, using the MMAI, multimodal artificial intelligence, which is based on digital pathology features, now also has level 1B by Simon criteria for not just prognostic, but predictive. It's the first predictive test in our guidelines and I guess, MCRPC setting. And again, this is here for your reference. I will not read all of this or I'll get the cowbell, but this is the study we just published last year that trained and validated the predictive biomarker that I'll show you the results here. So it was trained off of 4 phase 3 NRG RTOG randomized trials, about 4,000 patients to train for a differential benefit of the use of ADT. It was locked, and then my statistician independently validated this work in RTOG 9408. It's the largest phase 3 trial that has tested the use versus no use of hormone therapy in over 1,600 patients. And of course, to show it's predictive, you need to demonstrate a biomarker treatment interaction. And that's exactly what we showed. I was trained for distant metastasis as the endpoint, and you can see the difference here where you have a sub-distribution hazard ratio if you're biomarker positive of 0.34, so a very large relative and absolute benefit. If you're biomarker negative, which was 2/3 of these patients, the hazard ratio is 0.92. So getting into now, what about prolongation of ADT, which is the standard of care in our guidelines for high-risk prostate cancer? Again, using the 22 gene genomic classifier, there's some pretty promising data here to help personalize treatment decisions. This is data from the NRG group led by Dr. Paul Nguyen that you can see in these high-risk trials. And these are what I would consider very high-risk trials from the 90s. A lot of DRE T3 disease, some of them up to 75%, high PSAs. You can see here that the Decipher low patients, very few of them are developing distant Mets. If you look at that y-axis closely, that's out to 20 years of follow-up. Decipher high is approaching 50%. And so how can you use this? Well, we talk about shared decision-making. Well, in Decipher high patients, the number needed to treat to reduce one distant Met at 10 years of this short-term versus long-term ADT is just 9. So that's pretty favorable. If this was a Decipher low patients, that's 33. So based on patient's age, comorbidity status, preferences, this is pretty meaningful. And now, Dr. Armstrong's in the audience. He presented this at ASCO. The paper is written, and this will be submitted. This is not yet commercially available, but very similarly, a different novel biomarker has been trained and validated in RTOG 9202, again, a randomized trial of short versus long-term ADT, showing we can identify about a third of high-risk men that derive absolutely no signal of benefit on the left, and on the right, a pretty pronounced benefit of using long-term ADT. So, of course, there is data that is out. This is preprint data, thanks to Dr. Attard and the Stampede group. But there's been many trials, actually, in the metastatic setting, which I'm not going to be talking about using these tools. But he reported, and so the preprint is online, of that Stampede sub-study of use of abiraterone. I'll bring your attention to the right-hand side. So they ran the 22-gene classifier test in this cohort. And you can see here that below the median score, which is around 0.8 for those familiar with it, there is absolutely no benefit of using abiraterone in this population. So not only is this, again, an ultra high risk, half the patients, if you just do a simple cut at the median, are not benefiting from years of this therapy. There's ongoing biomarker-driven trials. These are accruing very rapidly. 010 is for unfavorable intermediate. 09 on the right is for high risk. They're both primarily focusing on de-intensification, so shortening the duration or omission of ADT, because many of these patients, as I mentioned, like from POP-RT, are doing very well. And then a subset regarding intensification, usually with ARPI addition. The point of all of this, and I think the patient's talk at the very beginning to opening was fantastic, is why does all this matter? Well, in modern high risk with PSMA PET, which is a biomarker, if you screen out the node positive and M positive disease, patients do extremely well. And that's why many trials are focused on de-escalation. ADT prolongation has been shown in randomized trials to cause 2 to 3-fold increase in cardiocerebral vascular disease. We're putting out and be submitting soon, as well as the prolongation increases other cause mortality for every month you prolongate ADT. And then this was presented at GU ASCO, and this is in the metastatic, not non-metastatic, this is the metastatic setting of all the abiraterone trials that were reported by older patients. There's really not a signal of benefit. So we need to just be careful in this M0 setting, and I will await very much so the data from Atlas, Enzarat, and Dazzle-HiCap before I routinely use these agents in this setting. Thank you so much, appreciate it.
Thank you to all the speakers from this morning. As a medical oncologist, this is a topic that is not too familiar to me, but I thought the quality of the talks was excellent. And I would like to say that we have more than 400 people on the virtual APCCC meeting, and you can submit questions in the Q&A, and we have 15 minutes for Q&A now.
Okay, so we're welcome to come to the mics, and we certainly accept our virtual audience to send in their questions. So maybe I'll start with you first, Martin. Excellent presentation. Maybe comment more about the challenges in the inter-observer variability, particularly when thinking about staging as it relates to histopathology and imaging. And even the DRE, as Declan did a really nice job, reviewing that, whether it's primary care based or urology based, it seems the only thing that is truly not subjective is the PSA.
Well, I think the DRE, as Declan pointed out, is still useful as a surgeon in terms of defining the disease, deciding on nerve sparing versus non-nerve sparing. But there is again inter-observer variability, and it's how to describe it. I mean, in general, surgeons have a tendency to, if you're at the T2B, T3 level, tend to, I think, underestimate stage. And I think that, and this is debatable, it's hard to say because it's all so inter-observer, but there's, at least in my experience, a tendency for a radiation oncologist to call a T2B. A surgeon would call up to a T3A. So there is this shift in terms of interpretation. and that's limiting. I think the MRI we all incorporate. If you've got evidence from an MRI that there's extracapsular extension, that's going to change what you think your finger is feeling as well, and affect ultimately clinical stage. And similarly, volume of high-grade disease. If you've got a nodule with multiple cores of a higher-grade cancer, you're going to predict as a clinician that this will be extracapsular, and perhaps use your finger to drift from a T2 to a T3 as well. So I think that's why the DRE is somewhat driftable in terms of categorization, and something we have to interpret when we take care in that it shouldn't be a singular cutoff between risk. You shouldn't be high risk T2B versus or high tier intermediate risk T2B, and then all of a sudden high risk because you're T3 with no other risk factor to support that.
So Declan, maybe you could add to that, and also, the challenge that we have. This is such a great conference in that it's global, and you make the great point that not everyone has the the paradisic accessibility to MR. You're very lucky in Australia. I think you have it fairly ubiquitous there. But as you point out, in the U.S., we don't. We have discrepancies. So help us understand how you think about this selection and the stratification, especially not just with DRE, but throughout all the other variables.
I think if we could only do one thing in the high-income countries to improve overall outcomes of men with prostate cancer, it would be to make sure we have MR in the early detection pathways, because it will reduce the over-detection of insignificant disease. And that's been clearly shown in countries where there is widespread access. We do less biopsies, and therefore we find less insignificant cancer. So I think, for example, things like biparametric MRI being equivalent to multiparametric, as we saw in the PRIME study at EAU recently, will help. Having a 20-minute scan instead of a 34-minute scan with contrast, and having to have a doctor there. All these little things will help. But I think that's the number one thing that will improve outcomes, is having MR in the early detection pathway. And that's what the Lancet Commission pretty much called for. And I think the point about primary care is still really, really important. Maybe David will comment on it, but that data shows that men genuinely have concerns about DRE, such that many of them won't go in and have a chat with their doctor. So I think we can do more to remove DRE from the recommendations for early detection in primary care. David.
Yep. Just to pick up on Declan's point, certainly my experience in doing awareness talks on prostate cancer, the DRE is something which I would say is a large turn-off for the men. And it's very interesting, I think, to compare how men react to the thought of this to how women react to the thought of similar intimate examinations. But one of the problems that there is that the DRE, in my experience, is completely misunderstood by the prospective patient. They seem to see it as something much more dramatic and even traumatic than it actually is. And when it's pointed out to them that nowadays, let's say, it's done with feeling, whereas my initial experience of such things when I had prostatitis in my 30s, it was an absolute trial. Getting this education across there so that you can actually see, well, what is the point to this? What's the payoff? What's the benefit? What's the potential loss? And so on, and the limitations of it. To just increase understanding, increase the education, I think there'd be much less resistance. And of course, it's certainly something, as an initial way of trying to feel at least a bit of the prostate, it seems to be rather important.
Thank you. A question at the microphone?
It's a question to Dan. So first, thanks for the lecture. The Decipher test, you showed a profound value in discriminating the prognosis and the treatment, but it's very expensive test. Like in Brazil, there is no way around to send the material to the test. So my question is, for other solid tumors, is there a specific test, cheaper, easier, for a marker that add and to refine the prognosis and the treatment for prostate cancer instead of expensive and not available for many countries test?
Yeah, so
I can present the data, but 100%, I think, I took the slide out for time, but I think that if this was free, there's really no discussion, in my opinion, I'm happy to have that after, that this should just be standardly done. But because there's a cost component, and that's where I think if it is used to change a decision, that's why I always say do not order any of these tests if it's not going to change your decision. To some patients, and we have a patient here, I will tell you that in the US, out of pocket, there's a financial program. It's $400 if insurance won't cover it in the US. Most patients, and I live in Cleveland, Ohio, it's not the wealthiest city, patients will happily, if there's a chance at omitting ADT, which has costs, some of it's being far more than $400. I think that that's one of the promises of the digital pathology is in the US, I think the reimbursement is, the cost is far cheaper, and I do think that's going to be globally more rapidly adopted and probably have, I don't think they'll ever be compared head to head, but I think that it probably can capture at least a lot of the prognostic value. So I'm hoping that that can be, and we have a number of grants doing some things out actually not with exactly Artera, but in India, at Tata Memorial with other cancer types as well for AI. But in prostate, you got a lot of valuable tools. You know, I would say PSA density, I think % positive cores is a shame when I see targeted only biopsies because it's actually more prognostic than T-stage. It's almost as prognostic as a Gleason score. So, you know, use what you have available, but happy to talk. I do have international patients that get Decipher testing, but I know the company is trying to internationalize, to provide a cheaper option.
Nick?
Yeah, it's a great session. Just on the you've kind of half answered my question, Dan, but it was for Martin around percentage of positive cause, because what we've seen in our practice where everybody has an MR first is that we put lots of needles in the PIRADS, whatever, positive lesion, and hardly any anywhere else. So you end up with lots of positive cause, lots of high-grade cancer, and I'm sure we're seeing a big stage migration off the back of it. So I just would question the value of quoting the number of positive cause, because it's very contingent on your MRI practice.
Yeah, I would say the way we at least do it, and I'm curious how you all, is that if it's an ROI, it's just one core, right? If you just shove 5 needles into the same. So for us, we do a systematic and targeted, and even if there's 3 out of 3 positive in an ROI, it's just 1.
Okay.
We haven't moved away, though. I mean, that systematic biopsy from the prognostic standpoint is just incredible. It's incredibly prognostic. It's in almost every other cancer, when you think of T-stage, it's true like tumor size and depth of invasion. And so just be mindful, I guess, giving up that prognostic info unless we are relying more on like the actual volume of the MRI.
So can I follow up on that, Nick and Dan? I think that, I do TP, our TP biopsies in our clinic, now transperineal, all MRI directed. I think that obviously we rarely do biopsies without an MRI now unless PSA is high and DRE is abnormal. And we mainly target regions of interest. But I think that I do treat it like a battleship, and I increase the battleship game anyways, and I try to increase the number of cores through and around the ROI because we're not as good as we think we are in terms of targeting the ROI. And we want more cores that are positive. The TP approach reduces the risk of infection. Not particularly, it is uncomfortable, but with appropriate freezing, it's less uncomfortable. And by getting more cores that are positive, it allows you to gain access to a better estimate of the heterogeneity of what we have to deal with.
I agree with all of that. It's just that you then end up with a lot of positive cores. I'm interested in Dan's answer. Anyway, I'll stop talking.
Andrea Gallina, Lugano. Very great session. I just have one question regarding nodal staging and how to deal with this nodal staging. In the new guidelines, as Dr. Walz showed, there is the indication for doing an external lymphadenectomy if we do the lymphadenectomy. What is not so clear, at least in the last version, is when should we perform a lymph node anerectomy. I would like to have a statement from the panel on what to do, because I think that the role of lymph node anerectomy is not passed out. And I think we should, especially with the new data coming from APCCC, we need to discuss about this, because now there is no indication in the guidelines. So that's my personal opinion, of course. And so I would like to have your opinion on that, especially Jochen and Dr. Murphy, Alberto, whatever else. Thank you very much.
Thank you, Andrea, for the question. Indeed, when I was looking up the updated guidelines from 2024, they say that you should do an extended one, but they do not specify when and how to decide. And I think it's getting now more and more complicated. We learn more about the effect of this treatment the first time we have a clear sign that it is curative, not only staging, which probably will change the indications for it. Karim Touget, during his presentation in Paris, said all patients should undergo lymph node dissection. That was challenged by Freddie Hamdy saying, no, we should select. I think for the time being, we have the excellent tool from Giorgio Gandalia and from Alberto Briganti, integrating imaging, which seems to be so important, targeted biopsies into the decision-making. Nomograms, I think, the way to go to decide who should undergo a lymph node dissection or not. Personally, I like to do it, or I do it when in doubt, but I'm happy to skip the lymph node dissection whenever I can, because it just takes so much time. It needs to be done meticulously in order to have the real effect to it. So select your patients, and I think the best tool right now is the Briganti nomogram or the updated one from Giorgio Gandalia. This is my point.
I have a slightly different view on lymph node dissection, and we haven't done lymph node dissection for PSMA negative patients for many, many years now. And the EU guidelines this year were very, very different. So Jochen showed what they say about high risk. If you're going to do a node dissection, do it extended. But last year it said, do an extended pelvic lymph node dissection. So the EU has dialed right back. Why? There's no evidence lymph node dissection improves survival, and it causes complications, right? And in the intermediate risk category, it's completely dropped lymph node dissection. It used to say nomogram driven. Now it's not even mentioned. There's no talk of nomograms, and it's not even about PSMA. PSMA is part of the conversation, but they've dropped it completely. So I think we're seeing a sea change away from futile, nomogram-driven lymph node dissection that doesn't help patients. And PSMA will help select patients even more, but I don't regret not doing lymph node dissection with PSMA-negative patients, because it doesn't improve survival.
We have time for one last quick question.
Quick question for Dr. Gleave. Great talk. I'm not familiar with the N2 classification. I don't believe it's part of APCCC. Can you elaborate on that? N2?
You mean in the N1, N2
yeah, N1,
status?
N2, yeah.
I think that it's just whether or not you have, size of lymph node and bilaterality of lymph nodes. Is it a small volume versus larger volume regional lymph nodes? I think that the intent of staging is it small volume regional versus larger volume regional. Intrapelvic versus extrapelvic. Extrapelvic would be M1A. Is that the question that you had?
Like I said, it's not part of APCCC that I know of, but what classification system is that?
Just trying to estimate better. This is an evolving concept of how we better determine volume along with grade that ultimately predicts need to intensify versus de-intensify.
Great, thank you.
Okay, so I think we just want to stay on time. So we're going to move to our next speaker. But before, I just think one of the great things about this every two-year program is what are the trends, what are we looking forward to, and undoubtedly AI will be front and center in 2 years from now. So our next presenter is co-chair Neha Vapiwala. She's going to speak on radiation therapy for high-risk and locally advanced prostate cancer, schedules, boosts, fields, and more.
Good morning, thank you. And yes, I had a little fun with the title because while I have no relevant disclosures, my disclaimer is this is an attempt at a crash course on many different topics within radiation. So I'm going to do my best, and I wish us all luck. Okay, so let's start with some terminology. So when we talk in radiation oncology about standard moderate hypofractionation and ultra hypofractionation, these are the typical gray per fraction that we are referring to. And it's been established that dose-escalated external beam radiation therapy typically in older studies given in standard fractionation up to about 80 gray, has improved outcomes, specifically biochemical progression-free survival, distant metastasis-free survival, but not overall survival until more recently, in our presentation earlier this year at ASCO GU from Dr. Hennequin and colleagues on GETUC AFU 18, where modern dose-escalated external beam standard fractionation improved progression-free survival as well as overall survival when given in combination with long-term ADT. Very exciting, but nonetheless, we are always asking ourselves, how can we improve on this? And again, quick crash course. On the right here, you see the linear quadratic model. It's a very simple way of describing the relationship between cell killing and dose delivered. And it is tissue specific. So that includes cell death for tumors as well as normal tissues. And in general, for slower growing, more slowly proliferating cancers, such as prostate cancer, the feeling is that there's a greater sensitivity to the size of the fractionation, and so therefore we can take advantage of that. You can see the shoulder of that curve by giving a larger dose, whereas there's less sensitivity, if any, to the duration of the treatment. So why not capitalize on that feature of prostate cancer cells and give that dose escalation, but in less time? That's where our Canadian colleagues from Quebec, Prostate Cancer Study 5, did establish in high-risk prostate cancer through this non-inferiority phase 3 trial that compared to standard fractionation of EBRT, that moderate hyperfractionation, given as what's called a concomitant boost, can in fact be a safe and viable alternative. So this in many centers, including our own, is very much accepted practice at a minimum. Give more radiation in less time. To take this further, ultra-hyperfractionation, and oftentimes we talk about stereotactic body radiation therapy, or SBRT, that is a type of ultra-hyperfractionation that requires significant expertise as well as experience, but at the end of the day is really taking that therapeutic index and trying to improve further. Giving more dose to the target and taking advantage of the highly conformal nature of SBRT, the tight margins, the steep dose gradients. And we have relatively limited data in high-risk prostate cancer, but it is absolutely growing. And one of the earlier reports is the SHARP Consortium, which is comprised of 7 different institutions and 2 registries. And they reported on 344 patients with high-risk prostate cancer, follow-up up to 49.5 months. And a favorable toxicity and efficacy profile. So again, setting the stage for continued research in this area. And already in the NCCN, it is very much accepted that SBRT can be used for prostate cancer across all risk groups. And note, in practices with appropriate technology and expertise. And I bring back that linear quadratic model because although I pointed out that prostate cancer is sensitive to higher doses, we must always remember that late responding normal tissues are also sensitive to those higher doses. And so we want to continue to collect these data and make sure that centers are providing us with the information we need to do this safely. In terms of moving forward to boosts, I was asked to address. So the original version of boosting, if you will, whole gland boosting, is brachytherapy. The idea of more radiation therapy in less time, and what can be more efficient than directly delivering the dose to the gland itself. And many of you might be familiar with the ASCEND-RT trial, in which low-dose rate brachytherapy interstitial implantation was evaluated as a means of boosting compared to pure escalation through external beam. And although it did improve biochemical control to use the brachytherapy, there was also an association with worse late GU toxicity and no difference in overall survival even at 10-year median follow-up, despite continued improvement in biochemical control. So it did put a little bit of damper in the enthusiasm for this approach. And in the US, at least, in most places, when brachytherapy is used for whole gland dose escalation, it's generally high dose rate. And here's an example of a small phase 3 study with long-term follow-up at 131 months of median follow-up using high-dose rate brachytherapy boost, an improvement in 12-year relapse-free survival of 21% and a, quote, equitoxic outcome in terms of late effects. So again, no overall survival difference, but in general, high-dose rate brachytherapy, when used for dose escalation, is usually the preferred method where available. Now, in terms of microboosts, and this is a different kind of boosting, this has been enabled by, as you've heard a lot about already, multiparametric MRI, as well as PSMA PET and PET MRI. This idea of finding dominant intraprostatic lesions and how do we deliver greater dose to those regions within the prostate. The FLAME trial, as was referenced a little bit earlier, 571 patients, including high-risk patients, no elective nodal RT, and about 2/3 of patients receiving neoadjuvant ADT, looked at the delivery of focal simultaneous integrated boost. So again, as the rest of the gland is being treated, you are treating this dominant intraprostatic lesion to a higher dose, up to, and it's important to say this was a variable amount of dose delivered depending on what was safe and feasible for each patient, but up to 95 gray in 2.7 gray fractions. And there was a disease-free survival benefit, as you see here, at 72 months median follow-up. And also, patterns of failure reported decreased local and what's called regional and distant failure. I have an asterisk there because it's important to note regional and distant failure was lumped together, implying that there might have been a distant failure benefit. But in reality, this was really driven by regional failures, and the distant failures were not particularly different between the group that did or did not get the boost. So I don't think we want to overstate the benefit of this in terms of improvement of metastatic or long-term outcomes, but again, important to see the feasibility of this and the benefit thus far. What about the use of SBRT for microboosts? And this is where we have emerging data, and here's just some examples of small but important studies that are evaluating the use of SBRT to, again, boost those dominant intraprostatic lesions at various fractionations that are provided here. And again, the thought is that these appear to be safe and perhaps a more novel, most novel of all, hypofocal SBRT, really incorporating PSMA PET MRI defined focal boosts. It's important to note here, there are a lot of questions still. We think about SBRT, we often talk about fiducial markers for safety, we talk about rectal spacer gels. We don't know the impact of the spacer gels in terms of deforming these lesions and how that might impact the day-to-day treatments, and so there's still a lot that needs to be worked out in terms of technique and safety, but exciting work nonetheless. So, talking about new questions, but also an age-old question. I've also been asked to talk about pelvic lymph node radiation. So, the benefit of whole pelvis is something in high-risk clinically node-negative patients that we have been asking ourselves in our field for quite some time. RTOG 9413 was one of the original trials that looked at this in patients with greater than 15% lymph node risk per the Roche formula. And unfortunately, at further follow-up, there was no significant progression-free survival difference. You heard about POP-RT earlier from Dr. Spratt. This was a very highly imaged group, so 80% of patients who had PSMA PET, and a high-risk group compared to the 9413 with modern radiation therapy, image guidance, and we did in fact see a benefit to whole pelvis radiation. So there are still many centers where this remains a controversial area. Some people will treat the pelvic lymph nodes routinely in node-negative patients, some will not. We are awaiting additional phase 3 trials, as you can see here, as well as ongoing SBRT whole pelvis studies, which are going to be challenged by the inherent sensitivity of small bowel and the challenges of positioning. So more on that to be seen. As far as clinically node-positive patients, we have various database studies that demonstrate the benefits to overall survival of adding radiation in this population that previously did not used to receive radiation. You heard earlier about the STAMPEDE group, which is a higher risk population. Exploratory multivariate analysis of the node-positive patients in this group did in fact find a failure-free survival benefit for patients who had planned as well as received radiation therapy. So an argument to be made there. And finally, radiation for PET-detected node-positive disease, the idea of nodal-only oligorecurrence. As you'll hear from my colleague on the stage, Dr. Ost, more about this, but the PEACE-5 STORM is the randomized phase 2 superiority trial that looks at metastasis-directed therapy of PET-directed nodes, as well as 6 months of ADT, and in a group of about 196 patients randomized to plus-minus pelvic nodes. You can see here no significant differences in toxicity, very promising, as is the oligopelvis trial, a single-arm phase 2 trial providing the same, with simultaneous in-field boost to PET-positive nodes, appears to have excellent progression-free survival benefit and very well tolerated. So in my final slide, putting it all together, a lot of studies coming our way, incorporating all of this, incorporating SBRT, incorporating the treatment of nodes, evaluating hypofractionation, as well as biomarker-driven trials, which you'll hear more about from my colleagues. So there's a lot to be excited about. And with that, I will say thank you and pass it on.
Okay, so we now have debates. We're going to hear from 3 speakers. Our debate is how to best manage a fit patient with high-risk localized and locally advanced prostate cancer. The deck's a little stacked against our first speakers. We have 1 uro-oncologist surgeon versus 2 radiation oncologists. So we'll first have Dr. Alberto Briganti, and he is going to address the topic of surgery as radical local treatment as part of a multi-modality approach.
So thank you very much, dear moderators, and thank you, Silke and Aurelius, for this very kind invitation to defend, in a way, surgery in the setting of high-risk prostate cancer as a part of multimodal approach. These are my disclosures. So why should we consider surgery in this setting? In the lack of real evidence supporting the role of surgery in this setting, the main answer to me is to tailor proper approaches in patients with high-risk prostate cancer, which represents a highly heterogeneous patient population. So we really can do tailored approaches and aim for treatment de-intensifications in this setting, knowing that actually we can tailor proper use of post-operative treatments. Those opponents to surgery in this setting argue that surgery is actually toxic, a lot of side effects, and these patients should receive anyway radiation therapy after surgery, which is actually not the case. Now, like a surgeon being myself, it's really tough to defend the surgery in this setting. Why? Because even our guidelines have downgraded the role of surgery in the setting of high-risk disease, strange to say. So basically, high-risk prostate cancer, the guidelines say in case of CN0 patients, no clear indications about the role of pelvic lymph node dissection. If you do it in the extended, but no indication of that. Surgery is only a part as part of multimodal approaches. I don't think this is the case, honestly. And surgery deleted completely for the treatment of CN1 patients. And again, I don't think we have nowadays the evidence, at least not in last year, to say we changed the guidelines for these. So one thing which I would like to highlight is actually if you stage patients with PSMA PET and high-risk disease, you end up having approximately 20% of them with distant metastases, whether nodes on bones, but still, we have been treated patients with no negative imaging or negative imaging in general, while these patients had already micro-disseminated diseases. So what about surgery in the setting of RCTs? So we have 3 well-known trials that actually tested the role of surgery as compared to either active monitoring and radiation therapy or watchful and waiting. Can we derive information and to counsel our patients in the setting of high-risk disease? Virtually not. And we cannot use these trials, to me, for 3 main reasons. Why? First, sub-analyses are really weak because these were not specified up front. Second, competing risks of mortality in the, for example, known pivot trial, many of these patients were seriously ill. Third, because we don't have actually a good number of patients that were enrolled in these trials with the high-risk features. So we need to be very careful. Again, treatment intensification or de-intensification, patients with high-risk prostate cancer treated with surgery, in 30 or 35% of them, they end up in having specimen-confined disease, negative margins, PT2, PT3, no negative disease, and these patients honestly need to be observed. There is no need to give adjuvant therapy. And in absence of any therapy, the progression-free survival is really low. And many of these patients are cured in a way by surgery alone with excellent outcomes, also in terms of 10-year biochemical recurrence rates. What about positive surgical margins? So the opponents of surgery say, listen, you have these patients with end up with positive surgical margin by definition. This is not the case. The role of surgical margins has significantly decreased over time. Whether this is better patient selection or better use of surgery, we do not know. And honestly, the vast majority of these patients has microfocus unilateral positive surgical margin. And this is not impactful for patient outcomes. These are mainly multifocal positive surgical margins, which in the high-risk series are actually found only in 5% of patients. Lymph node dissection, this is old story, which actually is nowadays very attractive and very hot. We have heard the fantastic lecture by Jochen saying that negative predictive value is highly dependent on the risks of having lymph node invasion up front. Actually, patients with high-risk prostate cancer, they do have LNI rates of around 35%, 1 out of 3. But of course, the negative predictive value and sensitivity of PSMA PET is highly dependent on the patient's features up front, dropping significantly in patients with high-risk disease. So should we skip, as Declan was saying, lymph node dissection in high-risk patients with negative PSMA PET? I don't think we have the data to support that. What Declan says we have been skipping for several years is Declan's opinion. It's not supported at all by any evidence. So what about lymph node dissection? Well, this is very critical, very criticized trial from Sloan Kettering. You have seen these slides already. No benefit on BCR, but benefit on metastasis-free survival in patients receiving extended lymph node dissection, and the 2 arms actually received the same number of nodes, more or less. So, this trial is not yet published, but it's food for thoughts. And I believe that you have seen this slide already. The best benefit that these patients were derived were in the setting of node-positive disease, of pathological node-positive disease. And guess what? PSMA PET is missing a lot of microscopic PSMA pathological positive disease because it has intrinsic limitations of 5 millimeters, more or less. So honestly, we don't be surprised if we skip lymph node dissection and then this patient will have nodal recurrence, even in patients with negative PSMA PET. So why treatment intensification with surgery? I think this is key because now we are trying to actually understand who may intensify or who may be de-intensified. And with surgery, we end up in having the same outcomes of radiation therapy plus long-term ADT with fewer treatments, with the same outcomes with less use of postoperative therapies or combined therapies. This is evidence. It's not my opinion. So guideline states don't give adjuvant ADT in PN0 patients. Don't even give adjuvant ADT in PN populations based only on the Matheson trial, so very weak recommendation. Second, can we use the ADT plus ARTA, again, in these patients, even in the perioperative period? Honestly, there is yet not big evidence. The Proteus trials will be released soon, but not yet available. There are many phase 2 studies showing that if you combine the two approaches, you may decrease tumor volume, which might be associated, at least, with biochemical recurrence. But yet, we don't have any data supporting the role of intensified perioperative approach in this setting. What about chemotherapy? Actually, no clear indication of a real benefit of perioperative chemotherapy. So everything which we have given on top of surgery actually kind of failed to be associated with outcomes. What about adjuvant radiation therapy? We all know about the 3 trials of adjuvant versus early salvage, which changed significantly our practice. The guidelines anyway, and I'm citing the EU ones, still indicate the possible offer of adjuvant radiation therapy in patients with adverse features, PN0, or in some patients with PN1 disease. But the reality is this one. We have been decreasing significantly the use of postoperative adjuvant radiation therapy plus or minus ADT. This is the reality. And in our centers, only very few of them receiving adjuvant radiation therapy based on these studies, even though these studies are flawed by the limited number of patients with aggressive features included. What about CN1 patients? The guidelines don't even mention any longer surgery in this setting as compared to last year. So my impression and my guess, it was that in this year, a big trials come out saying no surgery in this setting, no big trial. So the guidelines have changed based on what? Nobody knows. So basically, the guidelines use and recommend the use of radiation therapy plus ADT plus abiraterone in CN1 disease. They don't consider surgery any longer without any head-to-head comparative study between surgery and radiation. The fact that abiraterone is improving survival as compared to ADT plus radiation therapy versus ADT plus radiation therapy alone does not exclude surgery from these patients, I believe. This patient will inevitably become impotent or incontinent, again, completely wrong. And these are the rates of nice, consecutive, and contemporary series of radical prostatectomies done in high-risk patients. The rates of urinary function recovery is 90%. Honestly, it's way higher than patients treated with open approaches, and is higher than patients treated at lower volume centers. We need to centralize many of these patients if we want to optimize outcomes. What about sexual function? Of course, we have an increased sexual function. This is crystal clear 20 RCTs, and of course, this is again shown by this study coming from high volume centers. But honestly, to me, 3 years of hormones or hormones plus something else is not doing good for erections either. So basically, surgery versus radiation therapy, this is an old debate. I don't want to go into that. There is no way we can do comparisons and good comparisons between surgery versus radiation based on biased retrospective series where patient selection is huge. So we need RCTs, and this is the only one, to my knowledge, that is testing cancer-specific survival as outcome between surgery versus radiation therapy. And this was my last slide. I really thank you all, and thank you again for this nice invitation. I will invite you myself to our scientific retreat in neuro-oncology at San Raffaele Hospital next December. Thank you.
And for the other side of the debate, I will call Dr. Piet Ost on radiation therapy as radical local treatment as part of a multimodality approach.
Thank you for having me. I only realized at the beginning of this week that actually it was a debate, so I had to change some stuff up. But nevertheless, I'm happy to defend pro-radiotherapy. I'm a radiation oncologist based in Belgium. These are my disclosures, but one of my biggest disclosures is actually I will only be discussing randomized trials, because that is what we do. I won't mention series, I will mention one. That's the one of surgery. So if we look at setting the scene, and I'm actually summarizing a bit what everybody does, there are 3 disease variables. We look at PSA, we look at the microscope, and we look at our TNM. And then what we do is we try to combine all these variables. And as you can imagine and already mentioned, a patient with only 1 risk factor does better than a patient with 3 risk factors. But also in between the risk factors, there's a difference. You're better off with a PSA of 21 and a Gleason 3+4 than having a Gleason 10 with a low PSA. But nevertheless, 1 risk factor is enough to treat the patient in the same way. And I think there is where the future will change, where we will more adapt. So looking at the treatment variables, we actually categorize our patients or our treatments according to castrate sensitive or hormone sensitive and resistant. We look at organ confined versus metastatic. Then we again subdivide low, intermediate to very high risk. If you look at the treatment, it's pretty easy. The more you move to the right-hand side, the more the patient actually benefits from systemic therapy. The more you move to the left-hand side, you mostly benefit from a good local treatment, or maybe even no treatment at all. Of course, high to very high risk is a difficult one. How much local treatment do you need? How much systemic treatment do you need? And that's the big puzzle we are trying to lay out in the upcoming years. So what is this multimodal thing that we're all talking about? Well, there are 3 treatment variables. There's surgery, there's radiation, and there's systemic therapy. So let's start with what I would call the doublet therapy. That's a good local therapy with systemic therapy. What is the evidence? And I will summarize a bit what has already been said. But we know that there is an interplay between our dose and our systemic therapy. We can play with that dose. We can give a low dose, we can give a high dose. We can play with the duration of our systemic therapy, shorter duration, longer duration. And this is just one figure, but behind this figure, there are several randomized trials. And as you can see, the line in the middle is our reference. That's low-dose radiotherapy. If you move up, you go to high-dose radiotherapy. And as you can see, as compared to low-dose, the difference isn't that big. Where's the big benefit? It's adding systemic therapy. And you move up all the way to the left-hand side where you increase that duration, you derive a bigger benefit on hard endpoints. So this is what we mostly do. And for patients with 1 risk factor, we now have contemporary trials where you give a high dose as compared to a low dose with a long duration of radiotherapy. And I just want to highlight one of the recent ones. This is the GTUC effort. And the question is, if you end up with 96% OS at up to 10 years, what is there to improve on our doublet therapy? Do we need an alternative therapy if you have this? So of course, what happens when you have 2 or more high-risk factors? Well, the narrative changes. This is your OS. This is worse. Why? Because these patients had more aggressive features. But these patients are not dying because radiotherapy has poor local control. No, these patients die because of metastatic disease. And you can increase the dose, you can do more surgery, you can do whatever. Nevertheless, a lot of these patients already have distant metastasis. Sometimes we pick them up with fancy scans, sometimes we don't. But these patients still have that issue. So how do we change this? Well, beautiful work being done, already said. Instead of giving ADT only, you add something. You add an ARTA. And you actually improve your OS. But still, you can still see that a proportion of patients is still dying from their disease. So more effort needs to be done. So what are the lessons learned from 3 decades of trials only? Well, local control is no longer the issue. We can boost with brachytherapy, we can do focal boost, we can increase the entire dose to the prostate. That's not the problem. Distant recurrences, and that is biology, is the problem. So do we need to combine it all for all patients? That is the question. And there are 3 beautiful trials that will hopefully be reading out in the next years where we escalate our treatment. I do think that not all patients do need escalation, and that's why I think we need to look at subcategorization here. And the future will probably be that we add more. And adding more, this is the Thunder trial. We're going to add PSMA PET. So I stepped on the train that I was not on 2 years ago. I stepped on the PSMA train. I was waiting for that. Thank you, Ken. But we also stepped on the Decipher train. And the same is being done in the US. So if you want to have Decipher in Europe, send me an email and you can participate in our trial. And this will be for APCCC 2030, I hope. So what about variables and the multimodal therapy? What happens when we look at quality of life? And that's important. I'm going to show you 4 figures. This is sexual function. This is bowel function. This is incontinence. This is urinary irritation. And if you ask me, what curve do you want to be on? I'm not telling you which is red or which is blue. But you know which curve you want to be. You want to be on the blue curve. The blue curve is radiotherapy. And this is one versus the other in a prospective cohort. It's not randomized, but that's all we have for now. So if we look at the monotherapy, surgery only, and you look at your preoperative variables, so if you have a biopsy score of Gleason 8 to 10, and one of these other variables, what is the risk that you require multimodal therapy? Well, this risk is very high. So why would you go for surgery if you need all the rest? And I do agree, if we can better select our patients, that would be great. But as of today, these tools are not really available. So often surgery ends up with a triple therapy. And we do have good data, but why do we need 2 local therapies if we can already do it with 1? So these outcomes of these triplet therapies, oncologically, they are not bad. So if you combine everything, it's not bad. This is from the radicals. So if you add radiotherapy, if you add long duration, it improves, just as we've seen with radiotherapy only. So what's the point of doing that surgical part? If you look at node positive, this is work from Daria Tilke. Indeed, adding radiotherapy does help, adding hormones does help, but what's the added value of the surgery? So if we look at the quality of life of this triplet, well, actually, if you add radiotherapy on top of surgery, you will have what I would call double trouble. You add toxicity, but do we improve outcomes? That's something we don't know. We only know that at this time point, we're adding something. And what we're adding is toxicity. And is this good enough if you know beforehand that your patient will have 90% chance of requiring multimodal therapy, why would you go for it? That's my question. So some concluding slides, if you have more risk factors, you probably need more systemic treatment. You probably don't need more intensified local treatment. We figured that out, how to do that. So that part is figured. We need to tackle the distant disease. Second conclusion, I think the doublet therapy offers excellent outcomes for these patients. So why would we need a triple? So for me, the triple therapy actually increases morbidity over the doublet without really a proven benefit. So why, as of today, would we want to do this? I'm happy to take any questions afterwards, and I hope to make it alive out this session room. Thank you.
And to conclude our session will be Dr. Jason Efstathiou talking about selection of patients for adjuvant therapy as well as their treatment. Thank you.
Great. Thanks, Neha. Thank you, Silke and Aurelius. It's so cool to be here with all of you. This is definitely the jam of prostate cancer meetings, so thank you. It's not a, oh, there we go. All right, disclosures. All right, let's start with a case. So a 55-year-old man with T3B node-positive Gleason 9 disease has a 7% chance of remaining disease-free at 5 years post-op, according to the Sloan Kettering nomogram. Should this patient be getting adjuvant radiation? If we turn to the NCCN guidelines, it tells us that patients with T3 positive margins, in general, should be monitored. That is a preferred approach versus treated. If they have lymph nodes, they could be either treated or monitored. And when being monitored, it means early salvage. So we know that there's been an increase in surgery for high-risk disease. It's been discussed nicely. This has led to an increased indications for post-op radiation and its use. And when we're talking about adjuvant radiation, how do we define that? We define that as no evidence of disease after surgery. It really means an undetectable PSA, right? And you're considering radiation for a significant risk of future recurrence based on pathology to improve local control and avoid dissemination of disease. So what is an undetectable PSA? I think in general it's defined as a PSA less than 0.1 in most contemporary studies. The NCCN says that if there's 2 or more increases or a PSA over 0.1, that becomes detectable. AUA uses the threshold of 0.2. Radicals says 2 consecutive rises with a PSA of 0.1 or higher, or 3 consecutive rises at any level. And then there are studies out there that say the optimal PSA really varies by underlying clinical pathologic risk of recurrence. So for high risk of recurrence, maybe a single PSA of 0.05 or higher should be the trigger. And in the world of adjuvant radiation, you've heard, there's lots of trials that have shown benefit over observation for adverse path features, yet the use, as Alberto showed, of adjuvant radiation these days remains very low, under 10%. And yeah, maybe that's validated by studies like Radicals, Raves, the Jetug study. We all know that when comparing adjuvant to early salvage, there was no difference in progression-free survival or freedom from non-protocol hormone therapy, and the authors said, well, therefore you should pursue a program of salvage. But I don't know if you've all seen the curves on the right, which is out in pre-proof mode in their long-term update from the Radicals trial. And it's really interesting. The primary endpoint was freedom from distant METs, and you can see the values there, right? It's trending towards significant. Their original primary endpoint was prostate cancer-specific mortality, and look at that, that's significant now in their long-term update. Does that mean we should be treating some patients with adjuvant? And this is a favorable cohort in Radicals. If you look at their inclusion, they allow just single risk factor like Gleason 7 disease or a PSA just over 10. So, but the conclusion was pursue early salvage. If doing early salvage, we know the lower the PSA, the better when you use radiation. Some have suggested threshold levels of 0.25 or lower as the threshold. But really, let's come back to this question. Shouldn't we be doing adjuvant? What about that long-term update from radicals? And radicals in these other studies were limited by patient inclusion. Less than 20% were Gleason 8 to 10, only 5% were node positive. And if there's going to be any benefit to adjuvant, it's going to be limited to a subset of high-risk patients. So if you look at this study by Tilke et al., in a large cohort, in patients with node positive or Gleason 8 to 10, T3, T4 disease, there was benefit. There was benefit to adjuvant over early salvage. And if you excluded the node positive, there was even more benefit. So maybe it should be considered in patients with very high-risk features. And what about node positive? Many retrospective studies, Briganti and others, have looked at this, suggest benefit to adding radiation to hormone therapy in node positive disease. And the Tilke study says that there's increasing benefit the more nodes that there were found at surgery, and especially if there's 4 or more nodes. So can genomic classifiers, as we heard nicely from Dan, help inform this practice? Yes. In the post-prostatectomy setting, there's genomic classifiers like Decipher. In general, if you look at guidelines, they say that you should only use them, as Dan said, if they have the potential to change management. They should not be ordered reflexively. But if you look here at guidelines, they'll say for T3 node positive PSA undetectable, Decipher should be used to be considering adjuvant treatment. And what is that based on? It's based on studies like this. If the Decipher score is 0.4 or higher, maybe there is a benefit to adjuvant over salvage, but not if the Decipher score is low. I actually really like this, risk stratification models that say if you have 2 or more of these risk factors, T3B, T4, Gleason 8 to 10, node positive, Decipher score greater than 0.6, there is a benefit to doing adjuvant over early salvage. Now, if you're doing adjuvant in some of these patients, should you add hormone therapy? We had a trial in the ERTC, but it failed to accrue, unfortunately. So we're extrapolating data from trials in the salvage setting that have shown benefit to adding ADT to radiation. There's an ongoing debate of whether there should be a PSA threshold, though, for the use of that ADT. If we look specifically at the NRG-RTOG 0534 study, it has shown incremental benefit to adding a hormone therapy to prostate bed radiation and then pelvic nodal radiation to prostate bed radiation. And so if you do it all, hormone therapy and pelvic nodal radiation, it's far better in all subgroups compared to prostate bed radiation alone, including in PSA levels of less than 0.35. What about the duration then if we're using hormone therapy? Well, again, we're not so informed in the adjuvant setting, but if we draw from the salvage setting and the Radicals HD trial, which has been presented at ESMO, not yet published, it was a 3-arm randomization to no hormone, short course, long course. And they allowed 2-way and 3-way randomizations. They ended up with 2 pots, no hormones versus short course versus long course. In the latter, there were higher risk patients, more of the T3, sort of T3 and Gleason 8 to 10 patients in that short versus long comparison, but still not that very well represented, right? It's still a minority of patients that have those kind of higher risk factors. But in the short versus long, there was a benefit to longer duration over short duration in the Radicals HD trial in terms of metastasis-free survival. So what about intensifying ADT? We just heard about, I don't know, is it called ARTA, RP, RC? I don't know, but it's one of those. The NRG-GEO008 trial is in node-positive patients. They can have any PSA above 0. That means 0.01 qualifies you. They're randomized to radiation, hormone therapy, plus minus apalutamide on study. So can we use genomic classifiers to inform the use of ADT in this post-op RT setting? Well, yes, in the salvage setting, Decipher has been looked at in RTOG 9601, and in the subset of patients that got early salvage radiation, if you had an intermediate or high-risk Decipher score, there was benefit, but not if you had a low-risk Decipher score. And so what do the guidelines tell us? They tell us that Decipher can inform the use of ADT with early salvage radiation, though the optimal duration is unknown. And what about AI? We heard about this again from Dan, Artera AI, digital histopathology-based machine learning tool. What about that in terms of informing ADT use with salvage radiation? This is kind of not even hot off the press. It's going to be presented at AUA next week, so please don't put this on Twitter or anything. I got permission to show this here. But in a multimodal AI tool, high-risk group, there is benefit to adding ADT to salvage radiation. But if that AI score is low risk, there is no benefit. Very similar to what we've seen with the Decipher score. So in conclusion, and Silke and Aurelia said, what do I do? What do I do in practice, right? I favor early salvage radiation over adjuvant radiation in most patients, but I use a definition of 2 to 3 consecutive rises at any level or increases to 0.1 or higher to trigger early salvage. I consider adjuvant radiation. I do consider adjuvant radiation in otherwise fit, very motivated, very high-risk patients with 2 or more of the following risk factors: T3B, T4, Gleason 8 to 10, node positive, Decipher score greater than 0.6. These patients were underrepresented in radicals. That's where you're going to see the benefit. And guess what? That update in radicals maybe shows benefit in a more favorable cohort to adjuvant even. So in high-risk patients, I use a lower threshold to initiate what I call ultra-early salvage or adjuvant plus radiation. You can consider monitoring with an ultrasensitive PSA and consider the trigger being 0.05 or higher for those high-risk patients. And if you're giving adjuvant radiation, it implies it's high-risk disease. So I do treat the prostate bed and pelvic nodes. I recommend short-course hormonal therapy generally, maybe long-term, depending on the risk factors. I'm extrapolating from studies like 0534. And I may consider genomic classifiers or AI tools to help with that informed decision-making. Ultimately, our goal is to avoid or delay radiation and its potential toxicity in those who we can, but don't miss a window of opportunity to cure patients who are guaranteed to recur. Thank you very much.
All right. Thank you to all our speakers, and we have time for some Q&A. Yes.
Hi, Mac Roach from UCSF. I'm very proud of my radiation oncology colleagues for clarifying the role of radiation. Both of those talks were great, and your talk was great too, although one clarification, RTOG 9413 is not a negative trial. And we can talk about that offline.
Thank you.
Can you please congratulate with me also, Mark, please? Because I defended surgery.
And thank you too, Alberto. Okay, you're amazing.
Sorry, I feel alone.
We love you.
I think, yes.
Yep. Yeah. So I'm Francesco Sangodolci from Barcelona. Actually, I'm a urologist, and I want to congratulate my colleagues there in the panel defending our practice. And so I had 2 comments actually to put on attention. One is about the data that were showed by Karim in the last Congress. I found it a little bit difficult to understand exactly the reason why there was such a result on this outcome in terms of metastasis survival, based on the fact that the trial wasn't designed for that. So the main outcome was the biochemical relapse. So the issue is it's the first time that we listen that the location of the lymph nodes might have some impact in the survival. So my question is whether there might be other factors, for example, intensification treatment that have been added, and maybe we need to wait for the results for this question from the paper. The second thing is about the actual issue regarding surgery or no surgery in this setting of patients. I think they should be highlighted the point that Professor Briganti showed, that is we are living probably a shift in staging, so we should be careful not in denying patients might actually benefit not a treatment but a monotherapy with surgery, and be very careful in actually comparing the side effects of these two treatment approach. I think in most cases, radiotherapy is underestimating the actual impact, especially in long terms. And the only trial that we got, and not the actual your data, Peter, is from the PROTECT trial. And the PROTECT trial is showing that after Hamdi last year showed that there's no difference. And actually, we know from the evidence, in study in Australia, that one of the main reasons of unexpected hospitalization of patients in urology departments, actually, radiation therapy, radiation cystitis. So I will be more careful in comparing the side effects of these two treatments. Thank you.
Just to make a quick comment, you know, about 80% of all randomized trials have been done with radiation as the primary therapy, and NRG has, you know, proudly, as the data I showed you from the correlative studies, many trials out to 20 years of follow-up. I've tried to find that, and yeah, I'd love to see if you could show me the surgical trials that have reported that. That'd be great. But these are very well done, centrally reviewed studies, and so I realize we all have our anecdotes, but in, you know, over 10,000 patients, we don't see this actually beyond 3 years. There is no difference in the hazard ratio of side effects when you look at 8 years, 10 years, 15 years. So the early side effects are really what predict the late side effects. So obviously side effects can happen long term, but I think this is mythical in terms of at 10 years, all of a sudden men's rectums are falling apart. They can, of course, happen just like small bowel obstructions or other adhesions or things after surgery, but I think these are, you know, uncommon events.
So can I make a comment on this? Because I think that we are talking about the extremely heterogeneous patient population, and it's a matter of definition. So it's true, surgery has never been correctly randomized to surgery plus other therapy over the last years as compared to radiation therapy. We need to be very honest on that also, that we don't have any head-to-head comparative trials between surgery and radiation therapy in the setting of high-risk disease. The only one, which is the PROTECT trial, honestly included patients with 2 favorable disease. I mean, we cannot extrapolate those data. So we cannot say that radiation therapy is the only standard of treatment in these patients. We cannot say that surgery is the only standard of treatment of these patients until we have head-to-head comparative data. Regarding the toxicity, well, we are all surgeons, and I'm not talking about the big data coming from the trials. Let's just be very basic, and honestly, all of us in the room being surgeons has removed bladders for severe damages after radiation therapy, and I did once last week. So these data exists, and these cases exist. Thank you.
Question?
Gleave from American University in Lebanon. And I disclose I'm a urologist. Mm-hmm. But I want to underscore the role of surgery in PT3 disease, which we've always done in the Middle East, and we get patients very late. Surgery has really improved a lot in the past 10 years, and I think quality of life is excellent. And many times, as mentioned by the radiation oncologist, Dr. Efstathiou, you're doing a single modality treatment in these patients, especially when downgraded. They're not always being committed to multimodality and radiation after surgery. So a radical prostatectomy with a lymphadenectomy, mostly extended in the high-risk patient, has a big role, and especially in view of the data you presented on PSMA, for example, and negative predictive value. If you don't operate, you may lose 30% of these that are really not going to be known in terms of negative lymph node on the PSMA PET. So I think I vouch for surgery. It's not on everyone. Of course, we have to use the overall ECOG status, but whenever possible, surgery should be the #1 modality in high-risk patients. I wanted the opinion of surgeons and radiation oncologists.
There's just not data to support what you're saying, in the sense that it's proven to be a necessary modality. You can, of course, make these claims, but in the CALGB trial, one of the very few contemporary randomized trials with surgery, 85% of patients by 5 years had to receive subsequent therapy or recurred in a contemporary high-risk trial. So it is the vast, vast, vast majority of patients that are having subsequent treatments at just 5 years.
I also didn't argue that surgery is bad. I argued that in these high risk to very high risk, the probability of the patient requiring multimodal therapy is still very high. I do indicate if you're better at selecting a patient that only would require surgery and no other therapy, that would be great. But I love to see that data. And often what we still see nowadays is a patient, if they have a T3B up front on MRI, they have a high Gleason score, they will end up getting radiation plus hormonal therapy anyway. So why would we give them 2 local therapies? Because we know that the quality of life will get down. If we add radiation, quality of life goes down. So that, to me, is the big thing. What are we exposing our patients to? Are we really benefiting them, giving them these multimodal therapies? And there is no data that we do. So if local control is already that good, and I do admit there are bad cases, but also with surgery, you've got your pulmonary embolisms, you've got your lymphedema, which I didn't hear a lot about lymph node dissection and lymphedema, which can be very, very bad. And everybody can come up with cases you did last week. It's called negative recall bias. Everybody has that. And you see that in the quality of life reports. There are outliers. There are bad patients with surgery, and there are very bad patients as well with radiation. It's with every treatment. But we can't know up front. But if you know up front that the patient will require 2 treatments, why do that?
Okay,
That's my point.
So I think we're running up on time. So, no, we're going to have to stop the questions, but a final comment from Dr. Gleave.
Oh, it was more of a question to continue this ongoing, never-ending debate. But I think that the question is, I think we're quite fortunate to have 2 modalities that are very effective for the most part, have side effect profiles that are manageable. But the issue of layering therapies, having surgery and subsequent postoperative additional therapies is a common theme throughout the vast majority of oncology, whether it's breast cancer, colorectal cancer, and others, where we do add in as appropriate radiation therapy and systemic therapies following surgery. So the need for layering of therapies is not a reason to actually discourage the role for surgery. But again, selection is key. And it comes back to, and it wasn't presented by anybody, but perhaps one of our radiation colleagues can just address the issues of 13 out of 14 propensity-weighted studies, thousands, tens of thousands of patients, surgery versus radiation, in the absence of randomized trials, which is an absence of evidence rather than an evidence of absence problem. Those propensity-weighted analysis are not, 13 out of 14 show benefit for surgery over radiation.
They did that for low-risk disease
comment
as well.
by Mr. Matheson, who's going to give perfect clarity. Then we'll go to the...
Let's solve it. Perfect.
Well, in an attempt to give perfect clarity, what I would say is what this highlights very much is the need to supply information to the patient so that the patient, where possible, is then able to make an authentic choice, knowing the benefits, the merits, the demerits, and so on, of the different modalities, combinations, etc. Because after all, it's the patient who's going to live with it. It's not the clinician. So trusting the patient, enabling them, empowering them, to me, from a patient perspective, is absolutely essential, so that they go into these things with their eyes open. And with their eyes open, with the authentic choice, what we found in the work that we've done, anecdotally and formally, is they're going to find it much easier to live with the consequences.
Thank you. If I may ask, I think this is a very important point, and I don't think it's really worth fighting too much, but inform well the patients and ideally inform them in conjoined visits, so you can really talk at the same time with the radiotherapist, maybe the oncologist and the urologist, and I think that's really helpful for the patients. Thank you very much, David.
So, we come to some selected results of the questions that we have developed over the past 2 years. I had the pleasure of working with Silke many long weekends, many long Sunday afternoons, and sometimes I ask myself, is it worth it? I think so, because this morning has shown that there are so many questions where we don't have the evidence or where we actually interpret the evidence differently. Some very basic rules of voting for the people who are new to the consensus. Declan has already alluded to that. We assumed generally, unless stated otherwise, that all treatments were available, no treatment on contraindications, no participation in a clinical trial possible, and the patients are fit and well. We are all experts, all the people on the panel are experts, but if they did feel not an expert in a specific question, they should vote abstain, and there's always a proportion of experts who voted abstain in the questions. As defined previously, a level of consensus was always 75% or more for one single answer option, or a strong consensus if it's 90% or more for one option. And unlike other consensus approaches, APCCC never tried to bring the panel to agree on one single answer option or a statement, but rather we developed consensus on how to ask the questions and which answer options to use, not to get a consensus on one question. And now we go back to the very beginning of this morning and Declan's talk. You have already shown the outline of the slide. So also at our MDT, a very relevant question. A patient with localized prostate cancer, clinically T2, so he has had a DRE, is positive, but CN0, ZM0, ISUP grade 3 or more cancer, but on MRI, clear evidence of T3 disease. What do the experts recommend? Treat it as T2. That's option 1 and in green, or as T3 based on the MRI, that's option blue, where you see 96% of the experts voted for option 2. And the second question, before we go to the discussion, also something we frequently see at the MDT, patients with clinically high-risk localized or locally advanced prostate cancer that are staged with a PSMA PET and have now, in this question, one positive bone lesion without the correlate on the CT component of the PET-CT scan. What do the experts recommend as next investigation? Additional imaging with an MRI, an X-ray, a bone scintigraphy, that's option 1, light green, 55%. A biopsy, if feasible, option 2, 20%. No further investigation. Call it as M0 because there's no correlate, 13% yellow, or no further investigation. It's an M1, it's positive on PET. Option 4, 12%. And we can discuss here. Declan, are you happy with the result of this question?
Maybe we can go one back only to show you, to add, no, the next one, that, and I thought that was quite interesting, that we have a consensus to do another investigation. So maybe someone wants to add here. So.
If we go back to the previous one for a second, so the reason I highlighted this in my talk is if we do this, if there's a patient who's T2 on clinical examination, but now we call him T3 because the MR is suggesting extra capsular extension, like the example I showed you, it probably doesn't matter so much for surgery, but it does mean he's on a different pathway for radiation because he's now on 2 years of ADT, et cetera, et cetera. So I don't agree with this unless we change the TNM and unless we change the traditional risk stratification. That's my thoughts on it. So I was the only, who else voted for T2? I was the only one, perhaps, was I? Did you?
4. No, 4.
4%.
No, 4 votes.
4 votes, sorry,
so
4
3
votes.
more people.
Who else voted? Dan did.
So they can out themselves now.
I voted.
We have to appreciate, though, that this, and Peter was just discussing this as well, is going to lead to stage migration, right? And that now outcomes from the past with T3 will look worse than they will now, right? I mean, and so we just have to factor that in as we think. I totally agree we should change TNM to include MRI results, but there are consequences we need to be aware of.
And I do think the train has left the station for MRI, to be honest here.
Just to quote APCCC 2022 with the PSMA PET, no? Yes, I agree, but it has huge treatment implications if we make the MRI as a treatment and used for treatment recommendations.
And we can't undo all those lovely trials that radiation oncologists have done over the years. For high risk, T3 actually drives quite a lot of it, even though, as we know, Gleason's more important. So we can't, that's why I don't think we should change it, because then we're changing the interpretation of all the really good radiation trials that have shown the value of escalation in high risk disease based on T3.
Stefano, I think.
Of course, I'm commenting on, this second question, I guess, and I will talk about that on Saturday. I think the point is that on the first question, you mentioned clear evidence on MRI. In this question, you just say positive. So I think it's all about what we have to define as a clearly PSMA PET identified bone lesion. And that's what I will emphasize on Saturday, that say it's our responsibility as nuclear medicine physician to establish what is clearly positive and what is questionable, because it makes a major difference. It would be the same for MRI.
Yes, could I comment on the first one, the T2 thing? Because, I mean, are you talking about a PIRAD-5 with gross extension into tissues, or you're talking about a marginal study on an MRI where the radiologist says large contact between it and suggestive of possible T3 disease? We should not start managing people on the basis of some vague radiology report when all of our long-term data is based on a digital rectal exam T3. So I think this response is terrible for patient care if we are going to suggest to the world that on the basis of an MRI that's a marginal call that we now made major recommendations about how long people take hormone therapy.
Here.
Yeah. Thank you very much.
Follow up real quick on that, Silke.
Yeah.
Is like any biomarker we have, MRI is a biomarker as well. And to change your therapy, where I have never seen a single trial showing that MRI can accurately tell you who benefits from use or duration of hormone therapy, we could never get, you know, any like genomic biomarker into a guideline without showing something like that. So I would just have extreme caution in changing your management just based on MRI alone.
Very good points. We put that all in the manuscript. Nick, maybe next, and then Martin.
We get I get a lot of email about what's T3 in Stampede, and to be perfectly honest, I don't know. But what I think has happened in the UK is that we've been using MRI for a long time, and I don't think many people are doing rectal exam. I haven't done a rectal exam for about 15 years, and that was because David Durnley forced me to in follow-up for the CHIP trial. As soon as CHIP stopped follow-up, I've stopped doing MRs. And most of the UK trials, all the PACE trials, the CHIP trials, they've used MR as the staging. I think de facto it has already happened in a lot of studies. So you're right about we don't know, you're comparing apples with oranges, but I think people are just, as Pete put it, the trainer's already left. If you're using MR, you're bound to incorporate it.
And maybe I can add to it. What you are looking for is for locally advanced disease, and I don't think it makes a difference if that is based on a DRE or an MRI. And we need to be aware that the sensitivity is not very good, so we're not able to identify all the extraprostatic extension, but the specificity is very good. You see something on the MRI looking like extraprostatic extension, it will be extraprostatic extension. So there are very few false positives, and if you're looking for locally advanced disease, I think MRI is able to provide you with this information.
Marty, you wanted to add?
No, that's okay. This come out this discussion.
Michael, I think?
Yeah, comment on question 2, which talks about a PSMA PET scan. But you can't actually get a PSMA PET scan really anywhere in the world because you do get a PET CT. So it already includes the CT correlation. So to do a CT after a PET CT doesn't make a lot of sense. To do a bone scan to try to clarify a lesion on a PSMA PET doesn't make a lot of sense either because bone scanning is vastly inferior. You're kind of doing an inferior test. An MR may make sense if you want to believe it, but I think our early experience is when you do the MR, you see a correlative lesion. And then after a while with experience, you stop doing the MRI because you realise the PSMA PET's always correct.
Okay, I think we have to go to the next questions. I guess there's a lot of discussion that we can have in the break as well. So now it's about treatment of high-risk localized and locally advanced prostate cancer. And we choose this question. So if you have a patient with high-risk localized prostate cancer, according to the Stampede definition, but N0 on next generation imaging, M0 as well, what is your treatment? And you see here 10% said radiation plus long-term ADT alone, 68% said radiation therapy plus ADT plus abiraterone. No one said plus docetaxel. And 22% offer surgery. Can we have a comment here? Maybe Alberto?
Well, I don't know how many surgeons were voting anyway in the in this poll. 22. So again, I want to stick to our previous conclusions of the previous sessions that we really do not have nowadays any head-to-head comparative data in this setting. It's a matter, again, on patient involvement, correct patient counseling. It's sure that the evidence is much higher with radiation together with additional treatments. But again, for a patient with CN0, M0 disease, I don't believe that nowadays we can support any treatment over the other one, except for the fact that if you go for radiation therapy, again, you have evidence that intensification treatment matters. This is what would be my final conclusion.
Thanks. Jason, can you say something about the addition of abiraterone, maybe?
Yeah, I think high-risk prostate cancer highlights, as our patient advocate has nicely said, the need for multidisciplinary care in clinics, that these patients be seen as a team and that there are team consensus options offered. I think you're seeing 78% of folks are doing radiation and hormone therapy, right? I mean, so there's consensus kind of on that piece of it. The addition of abiraterone, I think practice is getting used to that. It's also learning what was the definition of high risk in STAMPEDE, right? It was a pretty darn high risk group of patients. I think the consideration of ABI for those patients makes sense, but it is sort of evolving in practice.
Dan?
Yeah, I mean, I respectfully disagree with Jason in the sense that this is on next-gen imaging, right? And I think for the nuke med colleagues out there, if you took the STAMPEDE population, which was 40% clinical node positives, we're talking juicy lymph nodes, PSAs over 75 into the thousands, these are metastatic patients. If you look at pro-PSMA, when you're talking about that positivity rate versus here, I think when you're screening those patients out, these men have fairly favorable outcomes. And, you know, I think in Gerda Tard's study, it was over 34% had grade 3 side effects, and 2 to 3 years of abiraterone is, you know, has toxicity and cost to patients. So if this was conventional or historical or traditional imaging, whatever we will call it now, I would agree. But if this is PET negative, I would not add an ARPI.
Paul, do you want to add on to that?
This is Paul Nguyen from Radiation Oncology at Dana-Farber Brigham. So I'm also in the minority. I also voted for option 1. I just want to make the point, like Dan, that there's a difference between meeting the STAMPEDE definition and being like the patients that were on STAMPEDE. Because you can meet the STAMPEDE definition with as few as having 1 core of Gleason 8 and MRI T3 disease. But I don't think that that justifies abiraterone, because that's not necessarily the kinds of patients that were on STAMPEDE who had a median PSA of 40 or 39, who had 39% node positive. So I think we should just keep that distinction in mind.
Thank you, Paul. Karim, last comment.
Sure, thank you, Karim from France. So, I was really impressed by the abiraterone data in the STAMPEDE analysis for men with very high-risk localized disease. This is really enormous benefit by overall survival. But nowadays, we are using lutetium and PSMA PET as a staging procedure, and really, I think the jury is out. If truly a patient has N0, M0 disease by PSMA PET, actually, I really don't know whether I should prescribe abiraterone in the setting. To address this question, and I think the jury is going to be out for a long time, we are about to embark in a phase 3 trial to address this exact question, and we will actually randomize the role of an AR pathway inhibitor. So at least we will know in the future, but it will take time.
Thanks.
Can I make a comment on these? Because I think that I don't want to go back to the story of therapeutic role or lymph node dissection, but we should keep in mind that the only way we can correctly stage a patient like this is there are the nodes is an extended pelvic lymph node dissection, no doubt. So we should be also stick on the fact that there is no other staging procedure which is as good as PLND if properly done. Just to remind this, because we are of course counting on PSMA PET, but in this case, again, the risk of false negative is quite high and the sensitivity is low.
Good points. So as always, the questions are now put out of context here. And of course, in the manuscript, we have more time and capacity to also elaborate on these thoughts. So we continue with this ABI combination, and now you've decided for a patient that has high-risk localized or locally advanced disease to treat this patient with radiation, long-term ADT plus ABI for 2 years, but this patient is not eligible for abiraterone, and the question was, is it appropriate to substitute ABI with one of the novel AR antagonists? Piet, you've already mentioned it's ARTA. You didn't specify ABI here, APA, DARO, or ENSA. The votes are clear. It's not a consensus. 74% voted yes, and 26% voted no. So we have a lot of these questions on whether or not an extrapolation is appropriate. And the next question is, in the same setting of patients, again, high-risk localized or locally advanced disease that you treat with radiation plus long-term ADT plus ABI for 2 years, and in case this patient has no relevant toxicity, the question comes up in clinic. You stop ABI after 2 years, and the patient says, why do I have to continue this extra year of ADT? Can I stop ADT as well? Well, that's what the experts voted. 65% said yes in the majority of patients. And 30% said yes in selected patients that are at higher risk of cardiovascular complications, and 5% option 3 voted no. So maybe, I don't know whether we can have a statement from Nick on the substitution of an AR antagonist and also on the duration, because this is a frequent topic that we have now in clinic.
So on the substitution, mostly these drugs all look the same, don't they, in efficacy? And so it seems not unreasonable, but of course we don't have the data. For the second thing, I personally stop at 2 years. I mean, I'm very worried in these patients about over-treating them. So 2, I'm sure, is plenty.
Can we have maybe Jason or Neha commenting on that as well? So what is the American way? Do you stop after 2 years, or are you continue for 3 years of ADT?
I think we would consider stopping. Neha?
Yeah, in my practice, same, 2 years.
Can I make a comment on this, just to go back on the importance of prognostication of people? So I think in this specific case, it's kind of misleading to put together high-risk localized and locally advanced patients. And we all know that, for example, having CN1 disease, a PSMA PET, is a prognosticator for worse outcomes. So these patients are highly heterogeneous in this setting. So I will try to make some therapeutic options or considerations based on whether the CN status is there or not.
Good point.
Only most of the long-term ADT trials, like PCS, 4, right? It's only about 53% of men get 36 months. So we report these trials, but if you actually look at treatment received, most do not even receive, 18 to 20 months.
And these questions specifically were for node negative. We didn't specify, but we have a whole section of node positive patients where it looks a bit different.
So in the manuscript, it will be kind of separated. So now we go to the really interesting question of lymphadenectomy. I heard already that Alberto has some quite strong feelings. So now the question is, in patients for whom radical prostatectomy is planned and have a negative PSMA PET, do you recommend an extended pelvic lymphadenectomy? And we started with the NCCN unfavorable intermediate risk localized prostate cancer. And you see here it's kind of a third, a third, a third. A third say yes in the majority of patients. A third said yes, but only in selected patients. And 44% said no. If we go to the high-risk patients, this is a change. 61% said yes in the majority, 10% in selected, and 29% no. And if we go to the NCCN very high-risk patients, it's 70% in the majority, 8% in selected patients only, and 22% no. So, Jochen, Alberto, what are you thinking?
Well, I think that this goes in line with what we have been discussed over the last 30 minutes or so, the fact that the negative and sensitivity, negative predictive value of sensitivity of PSMA PET for nodal status is highly dependent on the baseline risks. And these are also reflected by the EU guidelines that do not include lymph node dissection in intermediate risk any longer. But again, in high risk and very high risk, the risks of having micrometastatic disease missed at PSMA PET is there. Now, one may argue that if they recur, then you treat the pelvis anyway in case of recurrence, so you may skip that. But still, you have a lot of prognostic information. Then, say something which was very true about the prognostic information on systematic biopsy in men with some form of visible lesions. The prognostic information that you may derive for a nicely done extended lymph node dissection includes the number of positive nodes, the extent of nodal invasion, Gleason score in the nodes, and more importantly, PSA detectable after surgery, yes or no. We should not skip the importance of prognostications in prostate cancer, I believe.
Mac?
The problem comes when you go out and tell urologists who are not familiar with doing extended node dissections that they should start doing extended node dissections in very high-risk patients who have a failure rate of 90% despite the prostatectomy, and then the patient gets lymphedema and blames me because I radiated him after he had an extended node dissection done by somebody who doesn't know how to do extended node dissections. So we need to be a little bit careful about encouraging people to do stuff they don't know how to do.
Well, I mean, this applies to every field of medicine, I believe.
Sure, I understand, but these guidelines are, you know, if you make them international guidelines and you say, if you operate on a very high-risk patient, you must do an extended node dissection. I mean, I think we need to clarify in the discussion part of the manuscript that understanding the risk and benefits that, you know, if these patients I think they'll do just as well with hormones and radiation if you remove the prostate and you don't do an extended node dissection.
So Jochen, do you want to comment on that? So should we centralize these very high-risk patients for surgery?
It's probably difficult to say what is the cause for the lymphedema, if that's a surgery or the radiotherapy. I think there's no clear idea on this. So for sure, in high-volume centers, probably there will be a better job done with regards of the functional outcome, which is very important with regards of the staging. And I think in this situation here, the staging is very important. And I would not say that it does not have an influence on the long term. You correctly stage your patients, you will take consequences out of this staging, being N1, having one node, having two nodes positive, and based on this, you might fine-tune the management of the patient, which will help you to have the most effective treatment for this specific patient with a minimum of side effects. And I think that is a great advantage because you're just not giving everything or one size to all patients, but you can really decide what might be the most appropriate solution. I think that is something we are missing inside of this data we are looking here, because an individual patient might do well with one approach or the other, but it's difficult to tell on this huge data which one might be the most appropriate treatment.
Thanks. So Piet was first, and then I think Alberto.
I just quickly want to argue that how far do we have to go to get prognostic information? If going that far that it causes potential morbidity, I think we're going too far. We abandoned this lymph node dissection in breast cancer. Why? Patient didn't live any longer. So we're completely switching that up. And in a lot of the other diseases, we're doing the same because we can still salvage the patients with good radiation, including the nodes in our field, without the additional morbidity. Even in the guidelines for node-positive disease, it says don't just give adjuvant ADT. So there's no specific point why we would go so far to get just information telling the patient you will die sooner. There's no point in that. So I voted no in all cases.
Okay, that was quite clear. So
which
really
was,
short
by the way, the wrong
Alberto
answer.
And
you know
Andrea, and then I guess Marty, and then we have to switch to the next question.
So let me just say something about the high volume provider thing. Honestly, this is true. But this is true also for radiation therapy. Exactly. I would never leave someone like in the middle, treated somewhat in the middle of nowhere with old machines and without knowledge of what they are doing. And the same applies to MDT. Everything is based on quality, so don't get surprised on that. Second thing, I mean, how much do we have to go far with prognostication? If you look at morbidities, let's change our minds. Advent of robotics, the way we treat patients, the way we manage patients after surgery, the rates of complication of EAP-LNDs has significantly dropped. In our series, we are going to publish that, is less than 4%. Is it robotics? Is it because we are centralized? We do not know. But let's stop thinking that this is invariably a morbid thing. It is not, if it's done properly.
Andrea, short?
Short, very provocative question. If we trust so much PSMA, why should we irradiate the pelvis? Why? We do not need to do the lymphadenectomy because it's not a staging procedure. It's not adding anything. But if it's N0, M0, why should we irradiate the pelvis if we are decreasing, we are de-escalating? And last comment, it's not a fair comparison saying that radiotherapy plus IDT is comparable to surgery, because surgery is alone, it's a standalone procedure, and it might stay a standalone procedure. If we start already with a combined treatment, that's not a fair comparison, especially for BCR. Just a provocative question, of course.
And we asked the question, and there were also some people saying, no, so don't worry about after the radiotherapy. So, Marty, all good? Okay, we go to the last topic.
The last question. After a long session, everyone is desperate for coffee and a bit of sunshine, hopefully. And remember, we are all friends, even though we debate heatedly up on stage. So to switch topic, just 2 questions we wanted to show. I skipped some now. In patients, the question is adjuvant or early salvage with PT3B disease, PN0 following radical prostatectomy and extended pelvic lymph node dissection, and ISUP grade group 4 or 5 cancer, undetectable PSA postoperative. What is your recommendation provided the patient has regained continence? In case of an R0 resection, option 1, 93% voted for monitoring and early salvage, only 7% voted for adjuvant treatment. And in case of an R1 resection, this changes a little bit, with 73% now voting for monitoring and early salvage and 27% for adjuvant therapy. Dan.
Oh, sorry.
So, Jason put nicely, I encourage you guys to read the update to the Radicals RT trial, which is really the largest of the adjuvant versus salvage trials. And I will tell you, I dislike adjuvant radiation, but those results are making me challenge my practice. There's only, I believe, 4.3% of patients on Radicals RT that meet this criteria of seminal vesicle invasion with grade group 4 or 5. So it's very few. The results of PROTECT are they're far closer to the results of radicals than if you look at the CALGB trial. These are very favorable patients. And if you take the hazard ratio for distant Mets, in every subgroup favored adjuvant with a hazard ratio of 0.68. And if you apply that to a trial like CALGB, the PUNCH trial, where there's 40% risk of Mets, you're talking about a 13% absolute reduction in distant Mets. So I have some major concerns here. Now, I think, as Jason said, lowering the PSA cut point, maybe to 0.05, which has been proposed by many urology groups. But I think more work is going to need to be going to this with longer follow-up.
So, Jason?
Yeah, so I voted option 1, but I think to Dan's point, let's look at this update that's coming from Radicals. In addition, this patient, the R1, I mean, that's not a high-risk feature. It's an adverse path feature, but it's not a high-risk feature. This patient has 2 other high-risk features, T3B and high Gleason score, right? And those are 2 factors, and there are studies suggesting potential benefit to adjuvant. And so I think we do need to rethink this. I also think this might be the right patient to get the Decipher in.
Right.
That might help in counseling with the patient, informed decision-making. It might change what you do. And I think for this patient, otherwise fit, good continence, that's what I'm going to do. That's what I'm going to discuss with that patient.
Yeah, unfortunately, as you know, Decipher is really something that's not widely available, also not in Europe. Alberto, and I hope you're a bit happy because the patient had extended lymphadenectomy. So last comment by Alberto, and afterwards coffee. Wedong, sorry, yes.
So I was just I would like just to echo what Jason said about the low likely impact of positive surgical margin in these patients. The second thing I would like to add is we need to go back to pathology report and see extent and type of surgical margins and locations. SPCG4, 10% of patients, they did have a positive surgical margin which was longer than 2 centimeters, which to me is having left the prostate inside to more or less.
So Vedong, really last comment?
I voted option 2. I'm in the minority, but a lot of patients around the world, we see this is our bread and butter, and we tend to overtreat. many patients don't come back on follow-up. They do not have close monitoring. And it is important that we treat them when there is a small window of opportunity, and that's why I voted for adjuvant.
Thank you very much, Veda. I think it's important that we know also what happens globally, and just because Declan confused everyone, so the Lancet Commission is not today, but tomorrow. Sorry. So this probably was just like a revenge because we gave you the DRE talk. So now it's coffee time and we can discuss there also a bit more. Thank you.